Okay. So, as I say, I suspect to be used to absorb some people who are late for my presentation. So, Professor Roupret and de la Taille are a little bit late. So, I will start and open the session of UDOU 2020, special UDOU under COVID. And thank you very much for being here. We are expecting millions of people to be on connections to follow our different talk. So I'm Erwan Flock, I'm a pharmacist. I'm leading NewMed Publishing, which is a company which hosts and organizes this little congress. But on top of that, usually we don't do only congress organization, because what we do is more medical writing stuff. We help people to publish. I used to be the New England Journal of Medicine representative for France during almost 10 years. And so those guys used to send me statistics to explain why they reject roughly 98% of their paper that they receive. And the most usual reasons for rejection are related to the content, but some minor reasons of rejection are related to the form, to the aspect of the manuscript, and that's what we do with my colleagues. We help people to do a good bibliographic search, to reference nicely and to format the papers, and to do the statistics, and to do the English. So, as I said, I am not a neurologist, I'm just a pharmacist, and we are some guys here in my company, experts in database and some software to help you publish and win some time when you have to do this kind of exercise, which is, of course, very important for you. Okay, so I will explain you what are our last feelings regarding the change of PubMed, and giving you some other tips that you can use. So I see Alberto Bossi who is there, with members of the faculty over there. We are expecting Mr. Roupret, de la Taille, Mr. Grande from Spain, who will also talk online. So again, thank you for your comprehension of the situation this year. You see me now, but you will see more than me two nice ladies, which are a blonde one, Melanie, and a darker one, Sophie, which are in charge of all the logistics. So if something is missing, if you want some help, assistance, whatever, please go to her. They will take care of you. We have also organized this congress due to the support, or thanks to the support of those people, which are extremely important for us. And I want to thank them very intensively this year, especially this year, but because they choose to keep on supporting us in this congress. They are in the room next door, so please have a look to them, go to see them, because of course it was not also easy for them to carry on spending those budgets due to the situation of the COVID that you know, of course, better than anyone else as medical doctors. Okay, so I will start my session on PubMed, and I will give you some stuff. So what you have to understand that we do a lot of trainings, and we are also there if you want to go further with those database software, Zotero, Stat, or whatever. We are here to help, and those two girls I designed, I show you, are also capable of explaining you or giving you more info if you want to know more about that. Okay, so what I am doing now is I'm going to surf on the internet directly on the PubMed site. This will be recorded and will be available also on the UDOU website if you want to see again and repeat the presentation. Okay, so this is a new PubMed. New PubMed, and of course some of you knew that PubMed Legacy, which was on service during the last 20 years. So that's the old version. Please forget it, and now go to new PubMed. Okay? So if I make a search, because that's the only toolbar, the only place where something is living on this internet website, and I ask to see, for example, the paper of Mr. Roupret M, okay, search. And if I go here, you know, that's the first observation. I just, you know, wondering, this is published in 2017 in European Neurology, and that's the first article which it shows, but the new search engine of PubMed, and so I'm wondering myself, but did Mr. Roupret stop publishing or writing something those last 3 years? Not exactly, but that's the first ranking. So, because PubMed use now by default a new criteria of ranking the articles, which is no longer the time. So if you want to get the most recent from the oldest that we used to have in the past, go here to display option and ask to see publication date or most recent. All right? And I'm most recent, and in that case, you will see that's the latest paper published by Mr. Roupret and also Professor Moser, and okay, right? Cool. So if you want to get back to the original classification, go there. I think that should be for you the first reflex. Otherwise, you will find paper which can date 3 years ago, 4 years ago, okay? So you have here, of course, new filters on the side. You see, as usual, they already exist in the past. You have now some graphic options, like this one, for example, you see. And if I want to open it more carefully, I can have all the years, and I have, you know, a graph of all the papers. So Mr. Roupret is now seems to decline from 97. All right, okay. So I'm taking advantage of his not being here in the room. I'm not sure. So what is nice here, I think, that if you study on a subject, particular subject, you can also show what is the volume of publication on this subject per year, and if it's something which is growing or declining, which indicates some kind of dynamic of the subject. Okay, so I will close this. Right. Of course, you can focus only on those last papers. Right. And look, I have added this. What is it? This is an impact factor, you know, scale. So if I want to upstream the impact factor, I will reduce the number of journals to the one which are above 6, which is now nothing. Okay? 2, right. Okay? So you can select the type of impact factor. Otherwise, there is also related to this extension. This is not in PubMed. It's an extension that you have to dig. You have to find in the extension list of Google Chrome. I will show you. But otherwise, you can also only decide to say, okay, I want only to find paper published in the first quartile of the impact factor of the journal of the category. You know, so you want only the 25% of the best journals in terms of impact factor in urology. And in that case, you get rid of a lot of secondary papers or secondary journals in terms of impact factor. That doesn't mean that the paper is interesting or not, but it has been published in something lower. Okay, so that's an extension I will show you, and I like it quite well. You know, in France we have a ranking of category A and B for the journals. A and B means the journals which belongs to the 25 best journals in the category, and those, if you publish in those journals, you get reward. Your hospitals get reward. That's the CGAPS system. So it's better. There is a clear incentive to publish in those top journals because your hospital gets money from this, not these journals, but from a criteria from the government, which has a budget allocated to the publication performance of all publishers, all writers, all authors in France. Okay? So then look, abstract, free full text, you know that. Free full text, to me now it's completely useless because I think you all know SciHub, where you dig all free paper that you want. So use the SciHub, of course. Of course, I'm not here to defend the publisher, and I think SciHub should be existing for a long time. So I strongly support SciHub, of course. Donc free full text is no longer useful here. And then you have all the type of papers, you know, clinical trials, meta-analysis, review. Why do I have those options? It's because I just open the shops, the filter shops, and the filter shops is here. I went maybe a little bit too quick. Additional filters, and there you can select every filters you want. Okay, tac. You select. Species if you want, humans or other animals, which is always pleasant. Languages, sex, subjects, journal. Nice. I would have expected a better options within journals, but to be honest, it's very limited. So I did my own filter with my urologic journal. I will show you. And here, age. So you can, you know, select all the filters that you want in the filter shop here, additional filter, and open them. When they are selected, you can again click on them to use them. So because in my use of PubMed, I'm using very often the same filters, and so I put them all here. Look, okay. So Mr. Roupret, for example, I know straight away how many case reports he has published, how many clinical trials, phase 2, phase 3, English and human, how many papers in French, how many guidelines, how many meta-analysis, review, and I also put here my own selected filters of top urology journals. So if I want to click here, I have only the 158 papers published in the top urologic papers. Okay, so I like very much those filters because it helps me to structure my bibliography and not submit kilometers of bibliography where when I have to go to page 1, page 2, page 3, like a Google search, and then I'm anywhere after 3 or 4 pages, I'm fed up and I don't go further. Okay, so I prefer to select those filters. To select those filters, you need to create a login within PubMed. I'm sure you already have this kind of a tool, but you need to log in. You need to create an account within PubMed to be here recognized. It's completely for free. There is no difficulty. Where am I? Okay, again, too far. Here. Okay, R1. And so there are different options with this account. First, the filters, and second, to create all alerts that you want. So, for example, if I want to be one of the first to congratulate Professor Roupret for his next paper, that's very easy. Because of my account here, I will do that, create alert, and I say OK. OK, Prof. Roupret, that's the name. OK, and would I like research by email of new search result? Yes or no, and I can decide also the frequency, if it's monthly, weekly, you know, every Monday, for example. So I start very well the week. And, you know, you can also receive an email explaining you that this very week Mr. Roupret has not published. So that means that if you receive that several weeks following each other, then you can go to see and to ask what Mr. Roupret is doing, because you haven't seen anything coming into PubMed the last 3 or 4 weeks. Okay, save. So I have now saved this alert, and if I go here on my account, I go here on dashboard. And with this dashboard, I can see, you know, my safe search. So I have 2 on Roupret, you know, is okay. So for example, I will get rid of one of it, and I have different research saved here. And what is nice is, for example, I know that I haven't gone to see any results on this research. I have, you know, it's been 2 months, July the 5th, that I haven't been seen what's the result of the research. And so if I click here, I have 5 new results. And so in that case, you can update only the results that the system is indicating you that you haven't seen the paper, which is, I think, quite nice. Okay? So now look, that's one first option, to create an alert. And second option is to create the filters here. Okay? And if I want to create a filter, for example, I go here, my NCBI filter. That are my filters, and you see that I done a filter which is top urology to select the journals I want to see. Okay, so I have here again popular or properties. These properties, this is again the filter shop that I just showed you before, and the filter shop are now, you know, regrouped by category. Age. Would you like something in adolescent? Okay. I click adolescent, and now adolescent is in my filter list. And same, what I like here, very nice, is publication type. And if I go to publication type, I can select here case report, clinical trial, phase 1, phase 2. I like very much also the guidelines, which are very extremely important for you, of course. Okay. What else? Meta-analysis, if you want. Excuse me. Okay. Meta-analysis. So you select whatever you want, and you will create your filter. So in that case, you use the filters that exist in the system. But you could decide to say, okay, I want to create my own filter. So in that case, for example, you know, I can come here, create custom filter. And I can say, okay, I want to create a COVID filter. COVID. All right? COVID. It's hard. I test it. Okay, tag COVID, save filter, and now the COVID filter is here. So if I want to see if Mr. Roupret has published something on the COVID, I go here, back to PubMed, advanced. I have here my history, so I can see the 750 papers from Mr. Roupret, and I can see here that there is 13 papers related to COVID. Okay? So now, to be more specific in your specialty, urology, what I like to do is, look, I come here, advanced, and I will create my own filter with only my selected journals in urology. I don't need to read and to have a research on the prostate cancer in journals of neurology, rheumatology, whatever. Okay, so in that case, look, I'm in the section of advanced search within PubMed. I go here and I select G for journals. Okay, urology. And now I have a list of all paper dealing with urology in PubMed. So I take this one, okay, and I carry on urology, and I will add with or, because I want paper published in this journal or in this journal or in this journal. Okay, again, urology, and I will take European urology. Tac. Okay, world. Okay, voila, and so I can also have a look here, and I will have all paper, all journals, only journals. Okay, donc I will World of Urology, show index, tac, zoo, or. Okay, so I can put that in history, add to history here. Okay, and if I want to create my filters of journals of urology, I select the list of the title of the journal that I just selected. I copy it, and now I will create my filter here. Create custom filter, and instead of writing COVID, I paste the journal, the title of the journal of urology. Okay. So that's the filter, save filter, up, Journal of Urology. And now, when I'm doing any kind of search, okay, prostate, search, straight away, I have the number of papers coming from those journals, Journal of Urology. Is that clear for everyone? So, for me, two very nice options here, create alert with the account and filters here. Do not forget to change the display option to have most recent instead of best match. I don't like very much the best match filters which is suggested by default by PubMed. Okay, so now two other things. One thing is this, the two extensions that I like, impact factor. And another one, look, you know, we have a very famous guy in France, since the COVID episode. Didier, Raoult, okay, azithromycin, all right. Okay, now if I do this search, okay, you see, d'accord, tac, 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 and look, below this paper, I have put an extension, which is a link to PubPeer. Do you know PubPeer? Okay, it's better if you can avoid to have comments on your papers in PubPeer. PubPeer is a post-reviewing process made by scientists. It's a foundation, and they are criticizing, even after their publication, the papers. So questions are raised, comments are expected from the authors. That means things are not clear. So you know, you submit a paper, you have a publishing process, peer review process, and so then the paper is published. That doesn't mean that there are no any mistakes remaining in the papers or some comments. So in France, we had a good scientist called Anne Perroche, which was supposed to be at the head of CNRS, National Center for Research Institute. And PubPeer has discovered that the vast majority of her paper were manipulated. Results were arranged, photoshopped into graphs and whatever. And so she lost the possibility of being nominated as the head of the National Center Institute because of PubPeer. So PubPeer is not something to destroy the work of the authors, but it's criticizing quite a lot, and it's important, I think, to see when you have, or if you don't have, comments in PubPeer. So it's better to have a lot of reference in PubMed, but zero reference within PubPeer. So at least you know that, for example, here, of course, I took an example which is particular because Mr. Raoult, as you know, is quite heavily criticized. I don't have any opinion. I have an opinion, but this is not the case too. Okay, and so you go then, I put the extension link, which means, you know, that all the comments from the author are related to the papers published by Mr. Raoult. Okay, so there are two extensions which are, I think, quite interesting. One is the impact factor for PubMed, and the other one is the PubPeer link, which can appear to related to different papers. Okay. So, first extension, I'm, surfing on Chrome, which means that it's better for those extensions to download Chrome or to use Chrome as a navigator to do your search on PubMed, okay? And I go here, this is more tools. This is French navigator, of course, plus d'outils, more tools, and you go to extensions, okay? And those extensions are the following. This is the list of my extensions, the one I use. The SciHub link I had with the oldest version of PubMed Legacy, a link directly from PubMed, a link to SciHub. Boom. So it's not available now with the new version, but I think it will come back. So have a look. If you want to add an extension, go to see on the Chrome extension list if there is a link, because it will be reactivated, I think, quite soon. And so when you make your search on PubMed, you have the link to SciHub. Click and... Okay, so I go here, extension, open the Chrome Web Store, and the first extension, which is quite interesting, is PubMed Impact Factor. That's the one, okay, donc PubMed Impact Factor, this one, okay. And this one shows impact factor and allows you to select Q4, Q3, Q2, Q1 percentile, quartile of the quality of the paper. It's on the side, above the filters which are normally presented within PubMed. That's clear? So you go there and you download, here it suggests me to delete from Chrome, of course, because it's in my my PubMed view. Okay, and if I go here, what I didn't show you with this extension, that's the extension here. Okay, and with this extension, you have also the value of the impact factor here. Okay, that means this is not unusual PubMed. You have to go to download this extension, PubMed Impact Factor, in Chrome to have the value here as well as the capacity to select and to upgrade the type of papers. Okay? So, voilà. Second extension, it's PubPeer. 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 Show links to existing PubPeer comments. So, once again, it allows, it suggests me to get rid of this, but you know, you have this link here below the papers, and you don't need to go to abstract format to see that there is a PubMed link. So I think it's quite important, because if you are interested to a paper, there is a debate on this paper, and you see the link, you go to the link, and you understand the debate of the following paper. So you are fully aware of what are the conclusions of the paper, but also the debate which is around it, if any. Is that clear for the extensions? PubMed Impact Factor and PubPeer for the comments. Okay? So I like this, and I will give you another another tip here. Maybe you know that. Early treatment of COVID-19. Okay, so let's take this one. You know that there is, I don't know if you use Twitter, Facebook, LinkedIn, whatever. I think you should, in a certain proportion, of course, but also because you are all very young and you might look for collaboration in Boston University or whatever. So I think it's better to organize a limited digital visibility, especially if you want to get closer to some teams, to react to their papers, to their publication. And for that, you know, I know that some of you might consider that it's a lot of time to play with social networks and social tools, but you know, if you take any of the publication here on PubMed, there is a score which measures the impact of every publication on the social network, which is called Altmetric. So if I go here, you know, I have here a score, huge score of 7,268, you know, on Altmetric. What does it mean? If I go more into details here, this paper published by Mr. Raoult that became very international, of course, 7,268 score. That means that this is where the people have reacted on the paper of Mr. Raoult. Be careful, that doesn't mean that they reacted positively regarding this paper. Huh? It's just a score, which doesn't mean that if the score is high, the paper is beautiful. No, the score means there is a lot of reaction, but doesn't mean if those reactions, doesn't say if those reactions were positive or negative. Okay, so 7,268. Okay, that's the impact of this publication in the news. That means journals, or you know, usual Newsweek, Estado. Okay, that's usual news. That's the publication which has been, you know, related and relayed in blogs. That's Twitter. And of course, at this level of people tweeting about this publication, you cannot analyze it, because there will be every opinion you could find. So that means, you know, 22,000 tweets. Here is Facebook, very much limited, which show that Twitter is much more important in medical impact than Facebook. Okay, Reddit, that's a US platform. You have also here the video related to this paper. This is Dimension Citations. That's Dimensions. It's the company which edit Altmetric. So do you know about this score, Altmetric? So that's a score which measures the impact of every publication published on internet journals, or I mean on PubMed journals. And that's the beginning of the introduction of social networks. So I mean, if tomorrow you want to ask the Boston University to for a post the fellowship in their university, I think maybe it could help to have a Twitter account and to try to tweet on the papers they publish to say, yeah, it's great, beautiful, superb. So when you apply, they will see that you are also aware of their paper. It's not a complete strategy. It's just to say you can also give some credit or give some impact to some publication through Twitter here. Okay, so I will show you how you can install Altmetric. Okay, so that means I'm going back to here to Altmetric. Tac. Okay. Okay, I'm PubMed. All right. So that means here, for example, Roupré again, search. I can go to, I don't know, for example, you know here, guideline. Okay, and the last guideline published by Mr. Roupré here. This one, for example, okay. And then I can Altmetric it. It's a little bit more discreet than Mr. Raoult. But of course, I don't know. So what can be also interesting here is if you are focused on one very specific subject, you will also understand who are the people who react on this subject and might be interested to get in touch, to connect to them through this platform of here, Altmetric. So to get Altmetric, you go on Google, Altmetric. Okay, that's the website here. It's free also. Okay, and here, look, I'm going to product, and I will come here to free tools. That's, I think, what's the free tools here. Okay, free tools, and that's the bookmarklet here, Altmetric bookmarklet. Learn more. Okay, and you need quick and easy, you know, you just need to put here first name, last name, email. Okay, and when you have done that, you can click here, get the bookmarklet, and drag it to your favorite toolbar. And then it's functional, and whenever you are on one paper, you can click and get the Altmetric score on the publication if you want. Okay. Last thing about Altmetric, I will show you. Altmetric top makes a ranking per year, you know, per year. So if I go to the top best score, Altmetric score of 2019, okay, so I go here, you know. It's in every academic scholarly discipline. It's not only medical. So I have here the top 100. Okay, and if I go here, you know, to subject area, I can see that 54 out of the 100 papers are related to medical and health science. And so, you have here the top medical papers which have been, scored by Altmetric. Here is the debate on autism and possible vaccinations, vaccination and possible autism, which says no. That's also a very nice study that I let you understand. Parachute used to prevent death and major trauma when jumping from aircraft, randomized controlled trial. Some people have a special authorization to run some nice study according to this paper, which has been published in British medical journals. Okay, so I show you quickly PubMed, the way of using and treating the reference, and do not rely on the spontaneous ranking which is given by PubMed. Change that, please. Okay, change that in display options. I show you the two extensions which are related to impact factor and peer review. I show you also the altmetric score, which is very easy to install on your computer. There is no problem about that. And I show you the way how to create an alert after having created your account, as well as doing your filters. Okay? But the most important function and option in PubMed for me is this. Look, what is the diagnosis of prostate cancer? Or complication of prostate cancer? Complication of prostate cancer. Usually, some of my fellows say prostate cancer complication, which is not stupid, huh? Okay? Search. And now I have, you know, something like 23,000 results. Of course, I have the usual filters to play with the top urology, everything, okay? But to me, it's not like that you interrogate PubMed for such a question. I'm doing this that way, okay? I'm going to here, M for major topic. Up, where is it? M, major topic. Prostatic neoplasm. Okay, show index. And in prostatic neoplasm, I have, you know, two types of prostatic neoplasm. I have a subtype which is castration resistant. I'm not interested by this one. I want to go back to the usual prostatic neoplasm. And I'm looking for, you know, I have here analysis, anatomy, blood. And I have here, straight away, you know, a special chapter which tells me that prostatic neoplasm complication 1,858. Okay? Add and add to history. So the question now is to understand why, with almost the same words, in one hand, research 14, I have 23,000, and with this as one, prostatic neoplasm complication, I have only 1,800. The difference is very easy to understand. In one hand, you have all the papers within PubMed who host those three words. Cancer here, prostate here, complication further away. Okay? And here I have only the paper whose major topic, main thematic, is or are complication of prostatic neoplasm. So, you know, can you imagine making a search with the treatment of pain? If you ask PubMed to show you every paper who has treatment in one hand and pain in the other hand, you have half of the PubMed content which comes to you. But if you ask them, please give me only the paper who are specialized in the treatment of pain, whatever the words are used, management of pain, therapeutic approach of pain, whatever, in that case, PubMed gives you those papers with these options. So for me, the most important option within PubMed, this is the way to use that. Okay? You have to understand that if you are doing research on prostate cancer, the terms which needs to be used in PubMed are not prostate cancer, is prostatic neoplasm. Why? Very easy, because I went here to something which is called the mesh database. And you know, within PubMed, you can forget all of this, all of this, all of this, but this is essential. Mesh database, okay? And I say here, I want to understand what is prostate cancer, okay? Search. This is just a database which contains only keywords and major words, not references. So here I enter by prostate cancer. It makes 32 suggestions about prostatic neoplasm. I go here to prostatic neoplasm, okay, and then I have these subheadings, this list of characteristics, which allows me to select what I want related to prostate cancer. So prostatic neoplasm, I want here complication, I take complication. I want drug therapy, I take drug therapy. Okay, and in that case, in my view of using PubMed, I use this restrict to mesh major topic. That means I want only the papers which main thematics are drug therapy of prostatic neoplasm. And then I put that in the search box, and now I can look into PubMed. And the filters comes after this. You heard, I think, I'm sure, about mesh and major topic, but do not hesitate to go and have a search in this database, which is completely related to PubMed. PubMed is a good supermarket to make your shopping, but you need to make sure that you shop with the right tools, and the right tools and the right words are located into the mesh database. Okay, it's 2:10. I think I'm done. Do you have any questions? Yes? Yes?
Just a very quick reminder. You cannot access on PubMed retracted papers.
Huh.
I know that there have been some very nice polemics recently on a couple of retracted papers.
Yes?
And there are specific websites in which you can find those.
Yes? Do you have the name of the website?
Can you?
I don't know. What was the polemic regarding, again, the New England and the Lancet retracted two papers related to the database they use to try to prove that chloroquine was not...
For example.
Hop, on va voir.
It explodes with your coronavirus.
Chloroquine. No, I don't see anything. I don't know. I need to check. I cannot answer, to be honest. I don't know. I think Vincent will have a look, and we'll let you know later in this Congress. Any other questions? Are you familiar with those extensions, altmetric score, and options for PubMed? I think you will win a lot of time doing this. It takes some time to create the account, but it's for free. It's 2 minutes, and then you can have a better understanding and a better access, I think, to PubMed, and don't lose too much time when you need to make your search, and at least to have relevant papers. Because otherwise, the problem with PubMed is the masses of articles, masses of publication, and the time you need to dig into those papers to understand how it is. Okay, so thank you very much for your attention, and have a good urologic Congress, a good UDOU, and I hope that, again, you can enjoy, and you can ask the faculty, and it has to be very interactive. Of course, it's much lively. And do not forget to congratulate and see also our sponsor for their courage and their permanent support. Thank you so much.
Okay, this is the faculty I was speaking to you about. So Bertrand Tombal will show up later I think tomorrow. Alberto Bossi is already there. Laurence Albiches, Alexandre Delataille, Enrique Grande. So the team from NewMed, there is Sophie that you have recognized maybe with her mask. She's organizing everything. She has been in charge of all details, and I can tell you it has been a nightmare with the COVID-19. At the beginning we had, what did I do? We had 70 rooms, then 22, then 35, then no dinner, then a dinner, then no dinner, then a virtual dinner. It was so there will be a dinner. We'll create a UDOU cluster on the rooftop tonight. You see the weather is fantastic, so you will enjoy the view over Paris. I think everything is, every details are aligned to have one of the best sessions we ever had. Of course, we have some sponsor. We could not do that without the help, the financial help, and the scientific input of the sponsor, because there are a lot of drugs in the pipeline. And the purpose of this meeting is to discuss not the surgical aspect, because I'm a urologist, but the medical aspect of cancer. So we'll go through surgical tips and tricks. You go to the UDOU, you go to your national congress. This is not the purpose. What we would like to do is to dive into the oncological aspect of these diseases: bladder cancer, prostate cancer, kidney cancer. And these, behind this logo, there are some people. You can see, for instance, Dalila from Fering. She has been supporting us for many years. And there are many partners here. And it is important to keep this relationship that are becoming more and more difficult, because the politicians, they don't understand that we need the pharmaceutical company to develop trials, to do some research, and it has nothing to do just with the finance. So there are more and more rules, more and more laws. So to create an event like this, you need to overcome all the administrative issues, plus the COVID-19, which was on top of that. So we will start with bladder cancer. Maybe you have attended virtually the ESMO meeting, which was the last weekend. The ESMO meeting, it was a virtual meeting. We are supposed to be in Madrid. But anyway, the scientific commitment of all the people involved in ESMO went on. And if you look at the ESMO, especially when it comes to bladder cancer, we'll speak about that with Enrique Grande. But just to let you know, there was a huge hope with immunotherapy in the field of metastatic bladder cancer. And the only thing that you can keep in mind is that chemotherapy remains the gold standard for metastatic patients. And after, if they are responding well, there is avelumab as a maintenance treatment. So we'll discuss that further. So it's a bit disappointed what's going on in the field of metastatic patients. And these patients are very difficult to handle, because we know that the life expectancy has been shortened at this stage of the disease. So where I believe that we can impact and we can improve the management of the patient is in localized disease. And maybe just a small survey with a urologist in the room. You are the only one? Oh, okay. I was afraid. Who is a medical oncologist? Okay, 2. And who is a radiotherapist? 1. So some people are not doctors. Okay, anyway, we had to recruit anybody who was available for this course. So maybe you will get bored, but thank you for coming anyway. Please believe me, and I'm speaking as a urologist, we are not happy to take out the bladder as being a urologist and perform cystectomy. So what we should try to do is to define what would be the best strategy to avoid the cystectomy. In many, many cases, it is a difficult and complex surgery with a huge morbidity and the quality type of cancer. There is a paper which has been released by Gustave Roussy saying that in France, there is Elias from Lebanon. It's his birthday today. Happy birthday. Each year he's going to celebrate his birthday in France. So there is a paper which has been released like 4 days ago from Gustave Roussy, demonstrating that the mortality from cancer in France will increase from 5 to up to 10%. Alberto, correct me if I'm wrong, according to the COVID-19 situation. So it is also our responsibility as doctors to be responsible and to say, well, we are not saying that the COVID is not an element that we should take into account, but we have to deal with cancer and to continue to deal with cancer. There was a study that we published. Oh, mince, what is going on? All right. There is a laser here? Oh, yeah, okay. But it's not, okay. Laser on TV, it's not working. I thought it was a screen. And so we published a paper in France about the situation of the, and it was the team of Alexandre Lataille, Alexandre Ingels who published it, the impact on the surgical recruitment of the COVID-19 situation. And all hospitals were focalized and focused in treating one single disease, which is COVID-19. We have never seen that before, meaning that we were living apart all over disease. So it's a huge issue. And if this situation, and it is going to last, because if you look at the history of the Spanish flu, did you look at this? It lasts for 3 years and a half. So everybody after the lockdown say, there is a lockdown for 2 months, now we are done, and it's happy, and the family, no. It will last for 3 years. You are not going to travel. It's your last congress, physical congress, for the next 3 years, especially for any resident who is from France, because there is no support for anybody for a resident from France. So honestly, please enjoy. Because nothing will happen in your life in the next 3 years. So urothelial carcinoma, please, when you deal with bladder cancer, do not forget the upper urinary tract. And when you look at the recommendation, all the guidelines they're mentioning, you should do a CT. But it's not to look for metastases or nodes and so on, because the accuracy of CT is not that good, the predictive value is not that good. It is to have a careful look at the upper tract, because you are facing a multifocal disease. And most of the time, you are attracted by the bulky exophytic tumor, which is in the bladder, you have seen on the ultrasound, and you forget about the CIS, which is a flat lesion, and it's a particularity. When you look at colorectal cancer, you are a gastroenterologist, you do a colonoscopy, you find many, what you call polyp or exophytic tumor, and you will be happy. But as a urologist, you are much more, I would say, sophisticated, elaborated, because you need to go into every details and to depict as much as you can the flat lesion. And it has not been described very precisely in the literature, but the reality is that we have carcinoma in situ also in the upper tract. So it is absolutely important to keep that in mind, because most of the lesions that we can find from the bladder reservoir are coming from a primary tumor, which is, I would say, seeming from the upper tract within the ureter. Usually, it's not most, but a part. Usually, you have a bladder tumor because the bladder, as I mentioned, is a reservoir. So if you smoke, for instance, the worst cigarette is the last cigarette of the day. You know why? Because you will inhalate the toxic. You will so the entrance will be the lung in the body from the cigarette, and the exit door is always the bladder. Okay, so the last cigarette, you will smoke the carcinogen, and you will put it in the bladder reservoir overnight, next to the bladder wall, and you will create the perfect condition to initiate and to promote carcinogenesis. So anybody who is smoking should smoke in the morning with a coffee, because you will pee immediately after. That's a very scientific, strong argument based on a subjective evaluation that I have done on many people who are totally tobacco addicted. And if you spend time treating and dealing with patients with bladder cancer, you see many patients who underwent surgery, who are under treatment, they are still keeping smoking. And they are telling you it's too late. It's too late, I have the disease. It's the only pleasure I have in my life. Say thank you for your wife, who is sitting next to you. But anyway, you can quit. Why? Because if you quit, you will have an impact on the progression rate and on the outcome of the disease. So anyway, you need to involve the patient in the management of their own disease, meaning they don't have to sit in front of you and wait everything from you. You have to involve them in the management of the disease. So what are we talking about? Certainly about a bladder tumor, but the phenomenon in any solid organ is always the same. There is an initiation next to the cells with a carcinogen. So it will influence I would say, the apoptosis of the cell and the cell cycle. And then, at the end of the day, if there is no, I would say, capability from your own body to defend against this phenomenon, then the tumor will grow, and it will grow as an independent, I would say, body, and you will not be under control. But it doesn't mean that because the tumor is big, that it is aggressive. So when it comes to bladder cancer, what is absolutely important is I would say, the length of invasion in the bladder wall and the ability of the tumor to reach the vessels and to create or to launch the phenomenon of micrometastasis. and to go to the nodes and to spread all over the body. One of the issues that we have in bladder cancer is the quality of the imaging. You have seen in prostate cancer, and you will go through this topic, how we had an improvement in the management of the disease from the MRI, in active surveillance, also in the management of patients who had a primary care with a recurrence. The PET scan imaging is absolutely fantastic when it comes to prostate cancer, and not only choline, because in France we have a lot of choline, but there is a PSMA and so on, so you will discuss that. It is extremely disappointing in terms of bladder cancer. So today, there are a lot of colleagues, and I see many patients in my office coming already with a CT, an MRI, and a PET scan, a PET CT, when it comes to bladder cancer. But you look at the guidelines, there is no guidelines demonstrating the role of PET CT. And so far, we need to improve, I would say, this area of management for the assessment of the nodes when it comes to urothelial cancer, because we have a serious issue there. We have a serious drawback in the assessment of, I would say, the spread of the disease and the end stage, the invasion of the nodes. So it's absolutely important. The epidemiology of the disease in the Western world, especially in Europe, because most of you are coming from Europe, and I include Lebanon in Europe. Okay, my friend? So most of you are coming from there, and there is this proportion of between non-muscle invasive bladder cancer and muscle invasive bladder cancer. Most of the time we are facing 80% of cases non-muscle invasive bladder cancer. So this is where we can impact. And is there a role for immunotherapy? Is there a role for drug, systemic drug in this tumor? Probably yes. And this is what we will try to discuss today. You can see that bladder cancer is a very costly disease on the long run, because to make a long story short, there will be a lot of recurrence. So when you diagnose a patient with bladder cancer, you have to tell him that it is a long story, long-lasting story, and he will not be cured after the first time or the first procedure ever you will deliver. And it is a chronic disease, so you will see him for a long time, and you have to tell him from the beginning the truth about that, because many patients come to your office, they want to get rid of the disease, and they don't want to hear about it. No, unfortunately, they have been diagnosed with a very serious disease, and it will last for a long period of their life. And if you look at the mortality about bladder cancer, there was this publication which was really interesting. I don't know why you should wake up on Saturday morning to listen to prostate cancer, because every prostate cancer is cured now. It's 98% of the population. The mortality is not an issue anymore, except few cases who are all concentrated in Gustave Roussy with nodes and absolutely resistant to everything. But anyway, it's not an issue. But you can see that for kidney, there was a huge improvement, probably with the advent and anti-angiogenic agent, and now the immunotherapy will be a step further. But in bladder, there is a lot we should do. We came from 72 up to 77, and it is without the stratification between non-muscle invasive and muscle invasive bladder cancer. Meaning that when you face this category of patient, it's difficult. And the problem that we have is the survival rates. When you compare at static, the mortality from bladder cancer in the UK, it's, you can see, absolutely important. So you have to keep in mind this stratification between non-muscle and muscle invasive bladder cancer, to make it clear, because we are not facing the same disease. And what is at stake when it comes to non-muscle invasive bladder cancer is not the death, but the bladder reservoir. Will I keep it? And if I keep my bladder, will I keep it functional? And I'm speaking in front of my friend Alberto Bossi, because he will try to demonstrate at a moment in this day, or maybe tomorrow, I cannot remember, that radiotherapy has an impact on bladder cancer, certainly, probably on the mortality aspect, but also we have the quality of life aspect and the ability of the bladder reservoir to work normally, I would say. And so it's important, because we all know, and this is not an aggression against radiotherapists, that, for instance, BCG can have a caustic effect on the bladder wall, and some people have their bladder, but you will have to take out the bladder because of the side effect of the BCG, and not because of the side effect or the progression of the cancer. So it's not only an aspect of treating the tumor, but keeping the bladder alive, I would say. And that's very important, and that's not easy because any urinary diversion that we use is not very comfortable today. Every patient that comes to your office and it's time for a radical cystectomy, they say, I want a neobladder, because they believe that to take out the bladder will be replaced by a perfect neobladder. But the neobladder, they still have leakage, they wear pads, they wake up at night, and so on. They are disappointed after. And we have to be honest, we are not very good in delivering a good urinary diversion. We do it, we keep the patient alive, but it's not comfortable. And so their sexual life, their quality of life is largely deteriorated. So this is the frequency at the time of diagnosis. The median age is 65, 70 years old. So it is important. I told you the cytology, how useful it could be. It has only a value when it's positive, because a high-grade cytology has a good predictive value, but a negative cytology in a patient with a bladder tumor is not really meaningful, okay? And as I told you, the problem is that we have less and less pathologists, and there is probably, is there any pathologist in the room? Not at all. Okay, that's good, because it's a specialty that is going to disappear entirely from the surface of Earth. Because everything will be automated, and there will be laptop, computer, and so on. Even Google, you have seen, is producing a pen which is reading the tissue and giving you the assessment and the pathological diagnosis. So we'll get rid of these people, the pathologists. This is the reality. And so they are going to disappear. And the problem is that how are you going to do your cytology in the next few years? So maybe it's time to think out of the box, to think a little bit differently. What is important is to have the stratification. For many, many years in prostate cancer, they told you when it comes to localized disease, it's high risk, it's low risk, it's the, how do you, the criteria of, comment on dit, les critères de Martin? In prostate cancer, les critères du, d'Amico, I forgot. It's digital rectal examination, is totally outdated. So anyway, everyone knows D'Amico criteria, but no one knows the stratification for bladder cancer. So it's a pity. You should cry in your room tonight, thinking about that. What is extremely important is not only the prognosis, recurrence, progression, specific survival, but also what you are going to choose to influence. And I'm not going to dive into surgical step and surgical aspect, but there were innovation from the side of urologists, not only the side of urologists, maybe the company also, but the blue light, the daycare, the quality of the surveillance, and the treatment. Because they are not only systemic drugs. Medical oncologists think that they are only systemic drugs, but they are endocavitary drugs that you can deliver on site. And probably the way to go when it comes to an endourological tumor is not to deliver the pembrolizumab systemically. It's to deliver it locally, maybe. Or maybe there is a micrometastatic phenomenon and you have to treat the patient on a systemic aspect, but also within the bladder. Please keep in mind that today the FDA has approved pembrolizumab as a drug that you could deliver to any patient with a refractory tumor, refractory to BCG, and which is the case, and for a study with a single arm, and which has not been finished yet. So, and it was before the COVID-19 era when you discussed the chloroquine with the fast-track approval by Donald Trump. I'm just telling you that we are living in a world where the time of evidence-based medicine is not the time of the social media. And my point is that if you want to run and to have a good trial, it will last for 2, 3, 4, 5 years. And in the world we are living, it's not acceptable. We want a vaccine within 3 months. We are still looking for a vaccine for AIDS. It has been 35 years. But within 3 months, we'll find a vaccine for COVID-19. So this is the stratification. It's low risk. It's not low risk to die from bladder cancer. It's low risk of progression and low risk of recurrence. And it's important because the endpoint, when you are at the ESMO the ASCO, you will look at the endpoint of a trial when you look at the methodology. What was the endpoint? When you're on the metastatic stage, you will go for overall survival. You will go for PFS. When you are at this stage, the endpoints cannot be the same. So this is the reason why in many, many trials dealing with non-muscle invasive bladder cancer, the endpoints that have been chosen are totally different. Pathological complete response, CR, you will see complete response on the bladder. You will have disease-free survival, the recurrence within the bladder, or recurrence-free survival. And so it's important that you read between the lines because you will adapt the endpoint of a trial according to the stage of the disease that you are dealing with. And this is the reason why many trials that were designed in the field of non-muscle bladder cancer initially were, of course, discussed with medical oncologists who are used to deal with patients who are metastatic. So were a bit, I would say, inappropriate from the field perspective of the patient recruiting these patients. And we, as urologists, are pushing and struggling to have a shared discussion with the medical oncologist when it comes to designing a trial, when it comes to these early stages that we know, I would say, the best. And that is absolutely important. So you will look at the stratification, and then you will have an overview of the big picture or what is likely to happen in the field of non-muscle invasive bladder cancer. And you can see that many patients who are diagnosed with a low-risk, low-grade unique tumor are not likely to progress or to evolve at all. It's like going to the dermatologist and having a small lesion under your feet, and it will burn it, and will say, don't come back to see me again. Okay? But we do cystoscopy every 6 months and for 3 years. You look at the EAU guidelines, it's a lot. In England, the NICE has advocated the fact that you should stop any follow-up for a low-risk bladder cancer after 1 year. Any patient should be discharged. In Barcelona, Spain, Juan Palu is a good friend, Alberto Breda, they are doing only ultrasound to follow up this patient after low risk, after 6 months. One cystoscopy, then ultrasound. So maybe it's not enough, and the cytology is not recommended when it comes to low-risk bladder cancer. Cytology is only recommended in high risk. So it could be nice if we could rely on a marker that you can trust and which will give you the opportunity to diagnose any small, unique patient who is likely to progress from a low-risk tumor to a high-risk situation. Because there is never a black and white situation in medicine. It's never 100%. And what you do not want to miss is the patient, the unique patient maybe in your own cohort, who is likely to evolve despite he was diagnosed with a low-risk disease at the initial diagnosis. So we are involving so many nurses, so many cystoscopes, so many urologists to depict one single patient. So it's absolutely important that you understand that there is a tradition when it comes to bladder tumor in Europe to remove entirely the tumor. It's called transurethral resection of the bladder. In the United States, they do fulguration office. Fulguration office. So we need to work at the time when we are challenged on ambulatory care, one-day surgery, and so on, to develop maybe fulguration office for this small tumor in France or in Europe. And I don't know if you do that in your country, but that is an interesting concept, and there is no reason why. I was telling you about the quality of life of the patient. Each time you go deep in the muscle with your, I would say, the loop, and you perform a TURBT, you impact negatively on the quality of life of the patient. Because there are some patients, they underwent 15, 20 TURBT, so it's a lot. It's a lot. So this stratification is absolutely important because this is where we want to focus on high-risk tumor, and high-risk tumor can be missed. So if you do not diagnose properly the tumor at the beginning, you will miss the treatment. This is the reason why you need a good cytology from the beginning. Because if you have a positive cytology and a tumor low grade, then probably you have missed something, either in the upper tract or you have missed a carcinoma in situ in the bladder reservoir. It is a costly disease, I told you already. And it's a major health cost burden per patient. So that's a big issue. Why are we failing when it comes to bladder cancer? Limited awareness. People don't care about bladder cancer. There is the breast cancer day, the colorectal cancer day, but there is no bladder cancer day. So if there is one day in the year for each cancer, each type of cancer, it's not a very happy year. What is the day today? Is the diabetes, is penile cancer, is colorectal cancer, you imagine? So, happy day. But this is true that we are not raising enough money in the field of bladder cancer. Current therapies are not cost effective, current diagnostics are not cost effective, and the follow-up is the biggest issue. And I would be happy as a urologist if I could, at some point in my life or my career, I'm so young, so I have a lot of time ahead of me, oppositely with Alexandre Delataille, who is almost retired. But anyway, if I can impact at some point on the follow-up and the protocol of follow-up that we are request from our colleagues on the field, which is, from my perspective, totally inadapted. So insufficient new development. The cost, you can see, and some people will say, wow, what is very costly is pembrolizumab and chemotherapy. And now these people are living 6 months. So they have no time to be very expensive. What is costly is the coming back and forth to the hospital, BCG, transurethral resection of the bladder, and then chemotherapy, then the cystectomy. So on the long run, it's very costly. Okay, so it's and what you spend versus the mortality. Look at the cost. I told you, TURBT, the cost in blue, the mortality of the disease. Chemotherapy, the cost, the mortality of the disease. So please, when you have a problem or you are facing a situation, don't go into, I would say, the single concept or easy concept that saying, the chemotherapy is very expensive. This is where the cost issue is in bladder cancer. It's not true. Probably not true. So we should also understand that the diagnostic pathway is complicated. And when you look at bladder cancer, there is always a huge discrepancy between the guidelines and the reality of the practice. And there was a very interesting paper promoted in Cancer in the United States showing that out of 5,400 patients, only one patient received the recommended measures when it comes to the guidelines. And it's not to pinpoint the fact that the Americans are not doing well their job. They are probably doing what they can and what they do. It's just saying that it is totally difficult to follow the guidelines very on a stringent manner when it comes to bladder cancer for the simple reason that, for instance, post-operative instillation of chemotherapy after a transurethral of the bladder is something that is done in less than 6% of cases in France. I don't know if you have any idea of the way it is in your country, but it is written with a strong level of evidence that you should, in any small volume tumor, deliver mitomycin after the transurethral resection of the bladder. And urologists, they don't do it. Why? Because it is the source of complication. If you have a bladder or bladder perforation and you have extravasation of the chemotherapy within the peritoneum, it's the worst situation you would like to face. So they would say, I had to go deep in the bladder wall, so I would not do it. And 95% of the people are not doing it. So this is an example. So the solution, you see, we are facing low-grade non-muscle invasive bladder cancer, 50% of cases, high-grade non-muscle invasive bladder cancer, and invasive cancer. And we focused and we target, in most cases, this category of patient. And it was the case at ESMO. Plenary session, avelumab as a maintenance treatment in metastatic patients. Who cares? Who are seeing this patient today? Nobody, okay? They do not exist. They do not exist, and if you look at the population they had to recruit to build such a huge study with metastatic patients, they mixed up together many cases of bladder cancer and renal pelvis and ureter cancer. So they mixed up, you look at the population included in any metastatic patient with urothelial cancer, upper tract and bladder cancer cases, because it's very difficult to recruit. They are rare patients. So, should we or are we in a situation to use biomarker when it comes to bladder cancer? And what are the surrogate endpoints that we could use? Any biological, each time I have this problem, any biological parameter that you can measure and that reflects a physiological or pathological process. So it's a very broad definition of what could be a biomarker that could be useful. But there are certain points that are important. A good biomarker should be a diagnostic tool. It could stage the disease, it could help you for the disease prognosis, and for the prediction and monitoring of the disease. So that is interesting. Cytology, I told you, exists already, but will one day or another disappear. This is my own and personal conviction. Poor sensitivity for low grade, dependent on the expertise for a cytopathologist. I told you, these people are, you can take a picture of them if you know one, because they will not exist anymore. And frequent indeterminate reports. So urine as a sample, very interesting, because it's non-invasive. You have a lot of urine usually in the production, so it's not an issue for the patient to give you a sample of the urine. But it is difficult to sample the concentration of cells. And if you are recruiting urine for a male patient over 50 years old, there are, I would say, aging phenomenon that you can depict that have nothing to do with the disease aspect. For instance, hypermethylation in the cells. And also, you don't know if you are collecting urine cells from the urothelial wall, the prostate gland, the kidney, and that could be an issue. So probably this is where there is a room to use, I would say, a urinary marker. And as I told you, low-risk tumor is only 20% of tumor. You look at the proportion of death is extremely low. And this is coming from the NICE. The NICE is in the UK. And the people from England are extremely smart, usually, when they use the data. And they are, it's a country where they run very big trials on a large scale that are extremely interesting. So it's always interesting to have a look at the recommendation coming from the NICE, which is the National Institute for Health and Care Excellence. And for the low-risk non-muscle invasive bladder cancer, you can see that offer people with low-risk non-muscle invasive bladder cancer cystoscopy follow-up 3 months and 12 months after diagnosis. So if you look at the current pathway of follow-up, and if you look at what is recommended in the NICE, you can say, maybe I could decrease the number of cystoscopy. And increase, so look at the EAU guidelines office in low risk. You will do a cystoscopy. Is there any arrow, any green arrow? You use a biomarker, for instance. You will, let's say, which is performant. You do not eradicate entirely the number of cystoscopy. But in between each arrow, you will use a biomarker that any patient could do at home very safely without coming to the hospital. You will save 3 cystoscopies, and it's a lot of time, and maybe you will save a lot of money. But there is not a single marker which is reimbursed when it comes to bladder cancer. Intermediate risk non-muscle invasive bladder cancer. Look at the number. Each arrow is a cystoscopy. Alexandre, do you follow up this? Each arrow is a cystoscopy. You follow everything already. So you use a biomarker. This is a regimen. The problem is to build a protocol that could demonstrate, because as I told you, any protocol of follow-up, it's coming from the mind of so-called experts. It's coming, this is why it's coming with a weak evidence. And to build a protocol very stringent with a good methodology, it's much more easy to be an oncologist and to build a trial for a drug. Arm A versus arm B, the drug is superior versus the standard, and then you have the demonstration that it is useful, then to build a protocol to decrease the number of cystoscopy and to use of the marker. Because when you come in front of an ethical committee, they will say, the standard is to do 24 cystoscopy. Why would you propose to do only 6? And the ethical committee is going to say, you are putting some patient at risk, it's impossible, you cannot do that, and so on and so on. So that's very important. And for instance, another suggestion could be, I do 6 cystoscopies the first year, and then I use only the biomarker. And you will save 14 cystoscopies. I don't know if you are a urologist what is the flow of patient coming from a cystoscopy in your unit, but it is massive, massive. And it's a lot of time. So If you look at the history and the background of urology, this is the list of markers which were used. There were many, many posters in many congress. Nobody was going to look at that because everybody wanted to see a live surgery with a robot or something like this. But the reality is that the future is there, not with these markers because the technology was not very modern. But anyway, it is extremely interesting in the concept. So this is the previous generation of marker, and you can see the median sensitivity and specificity. It was not very convincing. If it was, it would have been already in your practice. So anyway, we don't care about this data. We are not using this marker anymore. I have a problem with this remote. So the ideal biomarker, in my mind, would be what we would have done in the Olympic Games in Japan. It was a success with the COVID-19. They build stadium, they build hotel, they sell tickets, they put Coca-Cola logo everywhere, and no Olympic Games. So, just for a small virus. So, adequate analytic performance, robustness, improvement in diagnostic accuracy. These are the, I would say, the rings of success when it comes to biomarker. Reduction of diagnostic tests, cost effective, and result available in a timely fashion. You want to perform a test, look at the PCR for the in your nose. I don't know if you have done it. It's very painful. Huh? You want to have the results within 24 hours, 36 hours. If you wait for 15 days, you will not accept it. So the turnaround has to be very rapid. And what we have now is some markers which have a good negative predictive value, meaning if we have a high-grade lesion, they will describe it. So I will show you what is available and what is the technology that we have. I will go fast. Voilà. Marker issue is the costs, the required volume of urine. If you have to produce 1 liter, you don't want to do that. So only 100 millimeter is acceptable, easy to assess and tolerant. So the new generation is summarized here. You have new markers which are relying on DNA methylation plus mutation, on RNA, or on mini chromosome maintenance proteins. So you have a company, I have a problem with this remote. You have a company from the UK, you have a company from Israel, you have a company from France, you have a company from United States, and there is a war outside challenging each company, challenging one another to be on the market very soon, to be available, to be used. But the problem is the reimbursement, because any pathway that you will use in Europe when it comes to bladder cancer will use something the patient will not accept to pay. I don't know if they afford the price of any treatment if you're in your country, but in France, everything is free when it comes to cancer. So your BCG is free, the cystoscopy you don't pay. And so the marker, they want to step in the market and say you need 100 euro. So if they want to survive, this company, it's not only producing meaningful data, it's to get the reimbursement. But today, any national authorities is requiring a phase 3 randomized trial to have the level of evidence that comes with the reimbursement. And they are not in a situation to provide any randomized trial. Small startup companies, they don't have the power of investment of AstraZeneca, of, I don't know, Astellas, of Ferring, of Ipsen. So these are small companies. And they are trying to launch and to make a revolution in the concept of the management of bladder cancer. And it is absolutely interesting because it is a new generation of marker extremely performant. And DNA methylation is absolutely interesting. And you have to understand that many data are coming from this marker. And maybe we'll be in a situation where we'll be able to screen the population. Because bladder cancer, there is no screening. But if you have, I would say, a subgroup of potential patients who are smoking in a category of population, 60, 70 years smoking, and you have a test that could do the screening, then there is no way you would be reluctant to do a test. If you have to perform a CT and ultrasound plus a cystoscopy to every patient, it's not called an acceptable screening. So I'm just telling you that within, I would say, I guess, if I bet, within 1 or 2 years, you will have marker that will come and be available on the market when it comes to bladder cancer. And it's absolutely important that you understand that because there is a lot going on in the field and it has very early steps of the disease and it will help you and influence probably the way you manage the patient. So what time is it now? It's 3. So if I remember correctly, there is a break at 3:50, no? 4, oh, okay. So definition of BCG failure, current perspective and treatment option. This is, do you see in your practice some patient who underwent BCG with a localized disease and you are discussing on the tumor board and they say, bah, cystectomy? No, you never see this patient? You don't deal with bladder cancer? You came for prostate cancer and you are totally disappointed by the afternoon you are spending. I'm sorry. So these patients, they exist. You know the stratification, I've shown that already. I've shown this. BCG failure definition. What is the definition? How many BCG do you do in any patient with high-risk tumor, diagnosed with a primary naive, and you have the pathological assessment, it says T1 high grade. How many BCG? Yeah, how many BCG doses of BCG? 2 years is, you can do 1 in 2 years. So how many would you do? What would you propose to the patient? Yes, T1 high grade, 3 centimeters. You have no idea? Yeah. So how many in induction? 6? Okay. 10? Oh. So just 1 year? But that's right, Elias, because for the simple reason that there are, I would say, maintenance courses that are, notably in the United States, advocating the fact that you should do 3 years, but it's a lot, it's coming from old studies and so on. So what we know from the literature is that in this population, you should do induction plus maintenance, and induction plus maintenance is superior to induction in terms of recurrence, induction alone. And the maintenance should be minimum or at least 1 year. But we don't know what is the perfect timetable for that. Maybe it's 1 year and a half. So it can go up to 3 years. But the reality, I don't know if you have tried to deliver 3 years of BCG to a patient, you will lose the patient or you will lose the BCG. And at a time where there was a BCG shortage, it was a real issue 1-2 years ago. So it was not the case in Belgium, really. No, you have it.
No, we didn't have BCG for 1 year.
In Belgium? But you don't have a government either. For 3 years. So I'm just saying that BCG, do you know the strain you are using in Belgium? It's Thais, no? BCG strain. There are different strains. There was a production of strain in France which was a Cono strain from Sanofi. And there was a shortage because they stopped the production of the strain, which was the same in France and on the US market. And so now in France we have the same strain that we have there is in Germany, which is the Medac. And I think in Belgium and in Spain the strain is Thais, but I don't know in Italy. The same times. So you see the production is different. But there is no real strong evidence from the literature saying that a strain is superior to another one. The only one which appears to be very good is the one which has disappeared, which is the Conote, which appeared to be the best, but the production was extremely difficult. So the BCG refractory tumor, and this is absolutely important, and it is complex, is whether or not after removing the tumor and performing BCG instillation within the bladder, you will you will have persistence or reappearance of the tumor, which is not the same story. In fact, it's a question of delay. Is it within 6 months after the diagnosis or after 6 months? And you can see, for instance, that if CIS, if CIS is present as 3 months and persists at 6 months after either reinduction of first course amendments, then you are refractory. Anyway, it's important because it's this category of patient where you are in a dead end. I mean, you say, okay, I will re-challenge by BCG. If you have a CIS, you all know that it is absolutely impossible to deliver chemotherapy, so you don't know what to do. And this is where there is a window of opportunity to treat patients differently from cystectomy, maybe with the pipelines and the drugs that are in the pipeline right now. So the definition is not the most important thing. The options is probably the most important things. What else do I have to propose after BCG failure in this patient? You cannot go back to chemotherapy if you had a high risk with BCG, which was not working, because some people are saying you should eat the chemo. It's called Synergo or HIVEC, but it's good for intermediate risk tumor. It's not very good for high risk tumor. So far, the first immunotherapy ever which was placed on the market has been BCG. It has been there for 40 years, and it's very difficult to challenge BCG in non-muscle invasive bladder cancer. So are we in a situation, when you look at the guidelines, where you can challenge it? Look, what are the options according to the guidelines? Radical cystectomy, strong. Okay. Enrollment in clinical trials, weak. Bladder preserving strategy in patient unsuitable or refusing RC, weak. Okay, so you have a table where in fact you have no other option than doing a cystectomy, which is a problem, which is absolutely a problem. Radical cystectomy again, I don't know what to do. So we need additional therapy. Current drugs are old, mitomycin, BCG, and we need alternative for initial adjuvant therapy. We need to challenge BCG, but not only in the refractory setting, also in the naive setting. And that's absolutely important. So when there is a new drug, and when you develop a drug and you invest a lot of money in the drug, you don't want to challenge what is the gold standard from the beginning. You will try the drug in a narrow, small window when there is nothing. Maybe a placebo. Against placebo, okay, I try my drug. If it works, I will go a little bit ahead. But you don't come and say, okay, I put everything on the table, I do it against BCG. This is why we have companies now developing drugs in that setting before the cystectomy, because there is this window of opportunity. But you have to understand that these refractory patients are highly selected because they are the non-responding patients. And the vast majority of the patients, they respond to BCG. So are we happy with BCG? Yes, because this is the only option we have now. But we would have something else, we would be even more happier. Okay? But the problem is that we have some trials, some data, very interesting, coming in the field of refractory, patient refractory to BCG. Highly selected patient with a mutational burden which is important, population of cells when it comes to cancer, which is different from the naive population, which means that if you use the drug at this step in the natural history of the disease, maybe you are not in a good, I would say, opportunity to assess the performance of the drug against the tumor cells. Just saying, not criticizing, but it is the reality. So what are the theoretical options? So BCG rechallenge, I told you what I thought about it. So you had a patient in your office, you say, I will do BCG. It's not working, comes back, you say, let's do BCG again. They will say stubborn, is narrow-minded. So you have gemcitabine. Gemcitabine is always work in many, many papers, but who is using it in the reality of the practice? Not that many people, because mitomycin was designed and the package is very well friendly user for the BCG, for the intravesical delivery, which is not the case with epiribicin and gemcitabine. So recently, aside from the BCG shortage, we had to face also a mitomycin shortage in France. So we are so lucky. We had to face a mitomycin shortage, and we started in few centers our experience with epiribicin. But you have to ask the pharmacist of your hospital to prepare and so on. So there are not very friendly when you call them to say, I have a lot of patients who have a tumor, a bladder tumor. I would like you to cook for me some epirubicin. So we have, I would say, a limited experience. Do you have any experience with that in Mondor, epirubicin in bladder tumor patient? Well, you see? They don't want to, to perform any research. So chemohyperthermia, I told you, it's not working. I'm not saying that the technology is not interesting and so on, but have you seen the Synergo? You put a device within the bladder. So I told you we do a lot of cystoscopy. It's very time-consuming to deal with bladder cancer patients. And now for any installation, you as a urologist will put a device in the bladder, hit the bladder wall, deliver the chemo. No way. Trimodal treatment. This is the specialty of Alberto Bossi. But on the three modality, he does only one. So he needs me anyway. Clinical trial. This is interesting. Because you have the preclinical setting, phase 1, phase 2, phase 3. And what you will face mostly is phase 2, phase 3. And there are interesting drugs that are in the pipeline. So trials that are finishing on unrolling in the setting of high-risk treatment failures. I'm not speaking of naive patients. I told you patients who failed from BCG. There is immune checkpoint blockade. You have heard of immunotherapy in a metastatic setting. We'll go into details with Enrique Grande. But you need to understand that the immune checkpoints, oppositely to what is going on in the field of kidney cancer, for instance, with Laurence Albiges, you will stay in the metastatic setting or advance. But it is interesting to see that in bladder cancer, these drugs are coming to the early stages, which makes it totally different because you encompass the possibility to use this drug in a curative setting, which is not a palliative treatment, and it's totally different. Vaccines, genetic therapy, drug delivery system, protein, radiation therapy. Radiation, Alberto will say a word. Let's go into a bit of details. Immunotherapy, we have the Keynote 057. Do you know what is a Keynote? Is any trial developed by MSD dealing with Pembro. So there is Keynote 122, Keynote 55, Keynote 50. Bon, who knows? But Keynote 57 was designed to deliver pembrolizumab systemically in patients with refractory tumor refractory from BCG. A phase 2, limited number of patients. And they recruited and they look at the complete response rate. So they deliver Pembro, they were free of tumor, and they check into the bladder again if there was any remnant tumor. And in one patient out of 2, roughly, there was no more tumor. And I'm telling you, there was a stratification between CIS group and non-CIS. The patient, the study, the trial is still ongoing, and the drug is already approved. Have you ever seen that before? So why would I run the study? Why would I still include any patient in the trial? So FDA approved drug pembrolizumab. And just saying that in one patient out of 2 it's working, and you don't know the duration of the response. What is important is, okay, if you are clear of tumor at 3 months, but is this a reality at 6 months, at 1 year, at 2 years? Because if you just postpone the cystectomy, then the medical service is not, what you want is to avoid the cystectomy, not to postpone. So the criteria of judgment, which is complete response, as I told you, be very careful with the endpoint that are chosen in any trials dealing at a specific stage of a disease, because it will have an impact on the way and the logic and the behavior that you have as a physician toward the patient and the explanation you will provide. Are you aware of enstiladrine? Adstiladrine. Because it's adenoviral vector with human interferon. It's, I would say, a therapy which in between an innovation, because you have the adenoviral vector and you have a gene therapy. together. So it's quite sophisticated. It's not the kind of drug that you are used to manipulate in your daily life. So I would say it's a new generation of drug. There is a particularity here, it's that this drug is going to be delivered within the bladder, which is a concept that is very seducing for the urologist. And it makes sense at this stage of the disease because we are facing an endocavitary disease which is persistent, which is refractory to BCG. So you will interact with the cellular DNA by incorporation of the virus. And it is extremely interesting. So what you need to understand is that, as I told you, there were some trials which were done with the Pimbro, which is a systemic drug. But now, I told you about this trial, which has led to the approval from the FDA. But what is interesting is what is coming after within the bladder. This is the paper, the first paper about the astiladrin, which was released in the Journal of Clinical Oncology for patients with high-grade BCG phase 2 randomized trial. And after, there was an update, I think 1 or 2 years after, at the AUA or SUO meeting, showing and assessing the efficiency of the instiladrin intravesical RAD interferon SINT3 for the efficacy. It is intravesical. So it is probably something that will be adopted in a broader manner by the urologist. Oncologists, medical oncologists are very well used to manipulate immunotherapy, EO, and they do it in kidney cancer, they do it in lung cancer, and so on. But as I told you, when it comes to early stages of bladder cancer, the urologists are dealing with this patient. So it's absolutely important to understand that the phase 2, and when you look at the phase 2, there were 43 patients who were recruited and assigned in the trial. And the way it was split has shown that the safety was totally acceptable compared to what we know from the side effect from the BCG. So no particular, I would say, comment I will have to do regarding the effect of the drug. I mean the side effect, because the purpose of a phase 2 is demonstrating and exploring this in particular. And what you want to see is the fact that the recurrence-free survival at 12 months was interesting, but the number of patients is very low. So once again, it's promising. It is something that you have to follow up on. You need to be aware of the existence of the drug, but what you want to see is larger population. And what we expect to do is to open some trials in Europe with you guys in your centers. And Ferring is endorsing, I would say, the totality of the drug soon, because it was a complex mechanism where a small startup in the United States was carrying the drugs, and the results were very promising. So now Ferring is more or less, I would say, buying the drug and endorsing this drug. And so Ferring will run a lot of trial. So in your centers, if you are aware of that, it is something that it is absolutely interesting. The phase 3 trial was then released. And it's important to understand that the endpoint which was chosen was the complete response rate. Complete response rate. So I'm not saying this is the best endpoint. I'm just saying that it is a new kind of endpoint that we are using, and we are not used to do that. And you can speak with any medical oncologist for Gustave Roussy. Complete response is not something that they are used to manipulate in their daily practice. And we are discussing the opportunity to open some trials in Europe with Ferring as a pharmaceutical company. Yes? Yeah, but you know that in that situation, the only option is cystectomy. but you have a good, I would say, oncological control, obviously, but you don't have a good acceptance from the side of the patient. So what we are trying to say here, that we are not losing a chance to perform the cystectomy if we treat this patient with the drug. It was the opportunity to demonstrate that in the phase 2 with the toxicity. The drug is well tolerated. In addition, if I postpone the cystectomy, if I do the cystectomy later in the patient who had the treatment and in whom the treatment was not successful, am I doing the cystectomy at a later stage? Is there a loss of chance? It was not the case. So anyway, there is nothing to lose if you are in this perspective, because the patient is accepting a treatment that will maybe postpone or avoid the cystectomy, and he has been warned from the beginning that he may have the cystectomy, and if so, it will not be at a later stage. So this is the reason why it was accepted. And if you remember the era of post-chemo in prostate cancer, when the ENZA, the AbbVie, all these drugs were launched, and now they are very early in the setting of prostate cancer, it was accepted also because there was nothing. And here, this is obviously a window of opportunity. But maybe, we need to think of a protocol with Ferring where we use this drug earlier on. For instance, let's say that we do transurethral resection of the bladder, BCG, 6, and then adstiladrin in one arm, and BCG in the other arm. Let's see what happens. That is something interesting. Or maybe induction with adstiladrin and nothing, and BCG and so on. So you have to design and to come up with an idea which is acceptable from the ethical committee perspective, not only from the pharmaceutical company whom you are going to discuss, not only the scientific question you want to raise as a doctor, but whether or not on the field it is acceptable to propose that to the patient. And obviously it has been accepted, and they got all the clearance from the authorities in the United States. And it is interesting to see the outcome. Complete response at any time among patients with CIS, you see. I told you about the outcome with the Pembro, and you see that in 55 patients, so 53% in a cohort of 100 patients, there was a complete response rate. So no evidence of disease. Within 3 months. So how long will it last? This is the question. But when they present the data, you only have the data, you can only expect some answer from the question that you had in the protocol. So disease progression, every slides I will make it available for you if you need it for your own presentation and your, voilà. Adverse event, as I told you, nothing that you could fear from a new drug was described as something that you cannot handle or overcome as a physician, I would say. Nothing extraordinary. So intravesical nadopharyngeal in firadenovec achieved a complete response in 1 case out of 2. Meaning that, is it for every patient? Is it a biomarker as a surrogate to pinpoint the patients that are the most suitable for this drug? Will it be a challenge in your center to deliver this kind new generation of drug to the patient? Because you cannot. I mean, you need to have a clearance. It's a gene therapy. So it's a promising option for a patient with BCG unresponsive. And you have to follow up on that if you are dealing with patients with bladder cancer. And you have to be keen to open any trial that would be proposed in your center dealing with this kind of drug. There are some more in the pipelines. Next in the pipelines, what is interesting is what we call FGFR inhibitor. There was a trial presented at ESMO assessing the FGFR mutation in a cohort of 300 patients, T1, and they have demonstrated that you can expect to have a FGFR mutation in 40% of cases, which is not the majority, but a large proportion of patients. It has an impact on the outcome, the prognosis of this patient, and also maybe it will pinpoint a category of patient who is likely to receive an FGFR inhibitor. So once again, maybe one size fits all will not be the rule forever, because we have been delivering BCG to every patient we had. It's like delivering neoadjuvant chemotherapy before cystectomy to any patient. It makes no sense. Some patients are not responder to chemo. Some patients should go straight forward to the cystectomy at the state of muscle invasive bladder cancer. And the fact that we have many options coming and under development in the pipeline should make us happy when it comes to non-muscle invasive bladder cancer. But it was the background about FGFR alteration. But I don't know if you're in your hospital, in daily practice, you do NGS, next generation sequencing when it comes to tumor. When you look at frequent mutation, it has a cost. For any patient, when you bring a sample and you ask for NGS for the most frequent mutation, it's 1,500 euros. So if you are in a big center when you can do that, okay, maybe you can do it, and this is what they do in oncology in my hospital for any metastatic patient with urothelial cancer, they do NGS for every patient, 1,500. So outside a clinical trial, it has a cost. And you can imagine that if you are in a big center with a high volume, people will send their samples for you to perform, not you, but the NGS platform, to perform this search for mutation, FGFR and so on and so on. So we have to solve also the cost issue. Because I don't know if you had this debate in your country, but in France, for instance, they were saying you are a low volume center if you do less than 50 prostatectomies per year for cancer. So you should close your center. It's called an oncological agreement. But it was never accepted, of course, because everyone is struggling to do his own prostatectomy and getting money from it and so on. But the point is that the selection will be done by the platform you will access. Because if you are an oncologist dealing with this kind of tumor in the near future and you don't have access to any NGS platform, then it makes no point or no sense for you to deal with these patients. Because it's a lot of money, but the molecular characterization is absolutely important. It's not fantastic when you are going to a congress, you get bored after 1 hour of a guy in front of his poster presenting the mutation and so on and so on. But the reality is that the next big thing when it comes to dealing with cancer is coming with this aspect of molecular characterization. And FGFR is probably one of the pathways which has been the best explored in bladder cancer. So it's important, especially in early stages. So it's important, and there are ongoing trials targeting FGFR. For instance, a trial with erdafitinib versus investigator choice for patients who were cured with high-risk bladder cancer. So once again, all the drugs are going in that small window of opportunity which is refractory to BCG, but you will see these drugs on an earlier stage very soon if they are successful in this subcategory of patients. So there are ongoing trials. I just want to let you know that behind the curtains, behind the BCG, behind mitomycins, there are many, many new opportunities for medical oncologists, radiotherapists, and urologists to work together. And we should be aware, at least, if we are not involved in the development of these drugs, of the opportunity that we have to enroll patients in some clinical trials. You should be a generation, because obviously you are young in the room, who are open-minded to put patients in trials and to convince them to go there, because it's always a good opportunity. And this is in the naive setting. Just a word about that. There is a phase 3 trial run by AstraZeneca, which is using durvalumab in naive patients. So it's not refractory. You perform a transurethral resection of the bladder, you remove the tumor, you have BCG in one arm versus BCG plus durvalumab. This trial is a nightmare for me because I'm running another trial, the Challenger, which is the Alban trial, which is run in France, which will expand soon in Belgium and expand in Germany. So what we are trying to do is the same story. We had the idea before, but as AstraZeneca, they move very quickly, so they open before us. But anyway, for any question, there are always 1 or 2 trials. So this trial is open. It's a phase 3 randomized trial, which is going to assess recurrence-free survival in patients with high-risk non-muscle invasive bladder cancer. We do a transurethral resection of the bladder. Then there is a randomization between BCG, as it was mentioned, following the guidelines, and BCG plus atezolizumab, intravenous drug. And so we have recruited more than 155 patients. But now the center of Alexandre de Lataille is likely to open soon, and we'll expect 50 patients within 1 month, minimum. And so Belgium will open, Spain and Germany soon. And to close the trial, we need at least 550 patients. So it's interesting, and we will see whether or not the adjunction, it's a combo, in fact, of local immunotherapy, the old one, and new generation immunotherapy, systemic, will add a benefit to the treatment of these patients. But once again, to define the best, I would say, dose for the drug of atezo, we had to come back with what we know from the metastatic staging. When we discuss with the medical oncologist, we say, how many times or how many doses of atezo are we going to deliver to this patient? No one knew, because the only experience we had with atezo was Invigor in the metastatic stages, where they tried to deliver for 1, 2, 3 years. So do we need to treat this patient for 6 months, for 3 months, or 1 year? So this is why, to stick with the definition of Elias, we came up with the plan to deliver 1 year of adjuvant treatment, to have 1 year of BCG induction plus maintenance. So the study is not closed. If you heard about it next to your place, please include as much as you can in this trial, and hopefully we'll have a conclusion, definitive statement within 2, 3 years after the chloroquine, after the chloroquine issue. Any question about the drugs that are in the pipeline in non-muscle invasive bladder cancer? Anything is unclear? Are you manipulating these drugs, dealing with these patients, or not at all, and you came for prostate cancer? Because bladder cancer is one of the biggest challenges that we have now. So we'll do a break, because you are falling asleep. I can see that behind your mask. So we'll do a break. Maybe, wait. In this protocol? After. But you, no. The protocol, I would say the window of the protocol is 1 year for the active treatment, active phase of the treatment. But you follow up on this patient further on after the end of the treatment. So you still follow the guidelines, because there is no guidelines mentioning that after 1 year you should quit the follow-up in high-risk patient. So you keep moving forward in following this patient, and there is only a recurrence, then you are outside, I would say, the active phase of treatment, and you treat the patient how you should do it in the guidelines. And most of the time you do a cystectomy. But if there is a recurrence within the time frame of 1 year, you will also ask and raise the question of the opportunity to do a cystectomy. So it's very well accepted by the patient, because when you speak... le téléviseur va s'éteindre. Qu'est-ce qu'on fait? Ça? Ah non, ça marche pas. La télécommande? Ça marche pas. Là? Ah merde. Ah, celle-là? Pardon, excusez-moi. OK. It's very well accepted on the field, because you see any patient with a primary tumor, you say you have a T1 high risk. There is a high risk of progression. The standard treatment is BCG. I have a protocol to propose. In one arm you will have BCG, in the other arm you will have BCG. Are you happy? Yes, I'm happy. It's the treatment. And you tell them there is a BCG shortage. I can guarantee that if you step in the protocol, you will have the BCG, because it will be safe for you. They will first allocate the BCG dose to the patient included in the protocol. So they are happy. And on top of that, randomly, you will have atezo. Are you happy? Yes, I'm happy. So the patient, if you do a protocol, robotic prostatectomy versus open prostatectomy, the patient comes to your office. He wants to have robotic surgery. You say, I will randomize, and I'm the surgeon, and I will do either robotic or open. They run away. They don't want to be included in the protocol. So a protocol, when you design it, has to be designed and you have to think of the situation, you being a patient, would you accept it? And if it was proposed to you. If it looks too much experimental, people are not really happy with that. So there are many surgical questions that you can raise that are important, but you will never reply by evidence-based medicine. robotic surgery is better than machin. You have some randomized trial in robotic surgery, but honestly, we all know that it has so many subjective factors. When you test a drug, randomly, you deliver a drug in one arm and not in the... So evidence-based medicine and the way phase 2 and phase 3 trial have been designed is only there to answer a question about the drugs. But there are many, many questions that we have in medicine that are not fit with the format of evidence-based medicine as we know it in phase 2 and phase 3 trial. This is why medical oncologists are very hard with us, because they are saying, you are living in a world with poor evidence-based medicine, low evidence, because with your surgical techniques you don't do any good trials. But it's impossible. It's difficult for us. You understand? Okay, let's have a break, and we'll be back, I don't know, when we start. I don't have the program. I will let you know. We will connect with Madrid. Okay, thank you very much.
Okay, so thank you so much, Dr. Bossi. It's a real pleasure for being here. Thank you so much to Professor Morgan Ropruet for this kind invitation and inviting me not only for being here with us today, but for trying to be there in Paris. I promise Dr. Morgan Ropruet did everything in his hands for being for me to be there with you. But unfortunately, because of the COVID situation in Spain, and particularly in Madrid, it's becoming a real nightmare. In fact, I was reading the news today. Well, probably next week we will go back to the lockdown again. And well, of course, the health is important, but the crisis, the economic crisis, the impact of the crisis in Spain is awful. I don't know what is going to happen, but let's see, and we need to adapt. And before starting, I want to mention thank you so much to Sophie and the rest of the technicians, because, well, you cannot imagine, yesterday we were doing all the technical assessments and everything, and you know what happened? That at the end we are using Zoom as the initial pre-plan it was. Okay. So the question is perioperative chemotherapy for locally advanced bladder cancer for those patients with muscle invasive bladder cancer. This is still a standard. Well, after my disclosures that you can see here, just in case. Well, this is the question and this is the answer. Yes. So I can come back home. Unfortunately, nothing has changed in the last 3 decades in the field of muscle invasive bladder cancer from the systemic treatment perspective, and we still need to offer for chemotherapy to our patients. Well, from my perspective, from my point of view, this is the current landscape that we have in the field of urothelial tumors, from the non-muscle invasive disease until the platinum refractory stage. Take a look at how many different systemic treatment options we have at each of these stages. Take a look at how this field has evolved in the last decade, or even I would say in the last 5 years. Take a look at in the platinum refractory setting, what are the approved drugs according to the FDA, not yet by the EMA, but shortly they will be approved by EMA for sure. And take a look at how these new drugs are slowly, but they are moving on early stages of the disease. In fact, I had the opportunity to listen some parts of the Dr. Ropruet presentation in non-muscle invasive setting, and well, it was mentioned how pembrolizumab is approved already by the FDA in this particular setting. Well, it means that we have a lot of challenges. We have a lot of new situations that we will need to face in the future. It's not just a matter of who is treating that patient, who is operating the patient, who is giving the medication. The thing is that both urologists and oncologists should work closer, should work together, as it never happened before. Because we both need to offer the patient the best treatment option at each of these consecutive stages of the disease. And I think it is extremely important and the main message for this talk. So we're going to focus on the muscle invasive stage. Well, around 20 to 30% of the patients are initially diagnosed when the tumor is already invading, is already infiltrating the muscle of the bladder layer. Cystectomy is the standard of care, and we can only cure that patient if we are able to do a properly conducted radical cystectomy to our patients. Okay, we can offer a neoadjuvant treatment, chemotherapy before the surgery, chemotherapy before the radical cystectomy, or we can offer our treatment adjuvant treatment, so it means chemotherapy after we are removing the bladder from the patient. And this is translated into a different rates, different level of evidence of clinical benefit in our patients. All right, one concept that of course we all have in mind, but this is I think good to put it into black into white. This is the correlation, extremely good correlation in between the initial stage of the disease according to the T status of the tumor and the overall survival. So the highest is the tumor infiltration in the layer of the bladder. The purest is the expected outcome in the patients. And take a look at how dramatic is the drop in terms of the survival in those patients with a PT4 stage. PT4 stage are almost considered a patient with an expected outcome very similar to those patients who has already spread metastasis at the imaging. So take a look at the drop in between the PT2, PT3. This is not that much different, and this is where we are going to focus on the neoadjuvant stage and in the adjuvant stage. Well, this is the summary of the clinical outcome we can expect in patients that are receiving neoadjuvant chemotherapy and adjuvant chemotherapy, and the 5 years related free survival for those patients with muscle invasive disease. Take a look at how it may change in between those patients with localized stage, localized to the bladder. 70% will be alive after 5 years, and only 36% of the patients with lymph nodes involvement will be alive after 5 years. So the relapse rate and the possibilities to develop metastasis are directly correlated with the initial pathological stage of the patients. Two messages here. First, in the last 3 decades, nothing, absolutely nothing, has changed in our systemic approach with chemotherapy to patients with muscle invasive setting. Second message, and extremely important, those patients with highly aggressive features, so it means those patients with PT3, PT4, the 5 years overall survival range only in between 10 to 40%. So it means that the majority of these patients will develop metastasis and will die because of the disease. So we need to take care of it. We need to work together, both urologists and oncologists, because the urologists can, of course, resect the tumors, can, of course, do the cytoreductive, this radical cystectomy, but probably these patients will not be cured without the chemotherapy. We need to try to get our best together to try to save as many lives as possible. Let me focus first on the neoadjuvant treatment. And well, these are the UDOU guidelines, and of course these are the best guidelines in the world of urothelial tumors. And as you can see, the recommendations for neoadjuvant chemotherapy for patients with T2, T3, and T4 stage are with a high recommendation, with a strong recommendations to offer for cisplatin-based combination chemotherapy. We will talk in deep about if we should use cisplatin gemcitabine or if we should use MVAC regimen here. Those patients that are not eligible to receive cisplatin should be operated straightforward. So those patients ineligible for cisplatin, and in the real practice, those patients ineligible for cisplatin means that around half of the patients in the clinic are not good candidates to receive this kind of agents, will need to be operated from the beginning. And immunotherapy, at least up to now, is just a promise. We should not offer immunotherapy as a neoadjuvant approach to our patients, and we should try to put all these patients into clinical trials. These are the message for the neoadjuvants. why we are using chemotherapy to our patients. Well, if you are using, no matter if you are using system or you are using MBAC, the response rate range in between 20-something% up to 50% of pathological complete responses. And why it is good to have pathological complete responses in our patients? Take a look at the survival curves. Those patients in which you achieve a pathological complete response or almost pathological complete response, the overall survival reach almost a plateau. So it means that the majority of these patients will be cured after the neoadjuvant treatment followed by the cystectomy. And this is important to take that into consideration. In addition to that, if we are able to induce, if not a pathological complete response, at least an important tumor shrinkage, and we can get that the tumor is getting lower than a PT2, the survival will be good enough. We cannot talk about curation of patients, but the survival will be good enough. So this is why it is extremely important to offer for the most active chemotherapy regimen, always cisplatin-based chemotherapy regimen, the only one that is able to offer up to 50% of complete responses, because this concentrated, this high dosage regimen will be leading for a pathological complete response rate in between 25-50%, that is translated into an improvement in survival. Why the EAU is doing these recommendations? Why the worldwide standard of care for patients with massive invasive bladder cancer is neoadjuvant first before the conducting the cystectomy? This is on these 4 meta-analyses we have. And these 4 meta-analyses, I have just ordered them chronologically. And as you can see, there are small differences in between them, and the more trials and the more patients analyzed, included in the meta-analysis, the more or the better is the positivity for survival. And I think, well, this is important to take that into consideration. Neoadjuvant approach based on cisplatin-based regimens is impacting in the survival of the patient with massive invasive bladder cancer. There is no other thing, this is not all the reason because neoadjuvant treatment should be given to patients. If we focus on the last meta-analysis, probably the most completed one, we can see that if we offer for neoadjuvant treatment to our patients with GemCis or with MBAC, the increase in the survival, in the 5 years rate survival, is about 8%. So it means that if we treat 12 patients, we are curing 1 of them because of the use of chemotherapy. I think we need to realize about this. And I think when we are discussing our patients into the multidisciplinary team, and always the urologist want to operate the patient as soon as possible, and always the oncologist wants to give the chemotherapy, the poisons, like my urologists are saying, I think it is important to have this number, this figure into consideration. Of 12 patients we are treating, we are saving 1 life. This is important, this is enough. This data should change my practice in the clinic? Well, I think it is. Those colleagues that are treating patients with bladder cancer, do you know what is the threshold for the benefit for those patients with bladder cancer to offer for neoadjuvant treatment? Only they are curing 4%. So I think it is good enough. I wish to have better data, and I wish to offer you better data than this, but this is the reality. This is in the field we are moving with chemotherapy. MBAC versus GSM. I do not really prefer one or the other, and maybe according to the patient I can use one or the other. According to the recent meta-analysis, it seems that gemcitabine plus cisplatin is offering for more complete responses, but it seems that MBAC regimens are offering for a better survival. I think there are a lot of bias on this, behind these numbers. I wouldn't say that the MBAC is having a better survival and GemCis more pathological complete responses. Use whatever the regimen you feel more comfortable. Honestly, I prefer to offer MBAC to my patients when trying to do a neoadjuvant approach. MBAC, in my experience, can induce more responses. can induce not only pathological complete responses, but more tumor shrinkage rate, which I think it is important, as we saw before. However, maybe this regimen is more toxic. But as far as you are giving MVAC only for 2 months, well, I think this can be tolerated. And of course, you need to personalize and you need to adapt your treatment options to the patient you have in front of. What is the major concern when we are using chemotherapy, neoadjuvant chemotherapy in our patients? Well, despite neoadjuvant chemotherapy is present and is the strongest recommended thing to do in patients with muscle-invasive cancer, not only in the UDOU guidelines, but in all the most respectful guidelines in the world, ESMO guidelines, NCCN guidelines. Despite of that, only 12% of patients in the US are receiving neoadjuvant approach before the cystectomy. 12%. This is also true that there is a trend to improve these numbers, and in the latest years, it seems that up to 20% of patients are receiving this approach. But this is still far for being the standard of care or for being the considered most references standard of care, at least in the guidelines. Why people in the community, why physicians, surgeons in the community sites are not really offering for neoadjuvant setting? Well, there are different reasons because of that. We will try to focus a little bit later on that. Well, as a summary, neoadjuvant approach with cisplatin combination chemotherapy is impacting in overall survival, is improving 8% the 5-year survival rate. I think this is something clinically relevant. I think this is something that merits to be discussed with the patient, to be discussed into the multidisciplinary team, and 1 of 12 patients are cured because of this approach. Neoadjuvant treatment in those patients that are responding, and especially those patients who achieve the pathological complete response, may be translated into an improvement in the survival and the curation of the patients. Immunotherapy checkpoint inhibitors should not be routinely offered to the patients. This is under clinical investigation so far. Results are extremely promising. We will discuss that in the next presentation. But today we should not recommend that in the clinic. Okay, let's go to the adjuvant treatment. And I know urologists love adjuvant treatment after surgery. And this is good, and the data are robust. And can we translate this data and can we compare data in between the activity of chemotherapy in the neoadjuvant setting versus the adjuvant setting? This is extremely challenging. Take a look at this study, this retrospective analysis, more than 5,000 patients recruited here. And as you can see, it seems that the use of adjuvant treatment, well, really impacts in the overall survival of patients. This is a large study, more than 5,000 patients, but take a look or simply think about the bias behind these numbers. And the bias we have behind these numbers is that, well, probably, those patients who receive adjuvant treatment were those patients in better performance status, with better conditions to receive the chemotherapy. Probably those patients that after radical cystectomy, it was not considered by the physician in charge to offer for adjuvant chemotherapy, probably is because of something, because of the poor performance status, comorbidities, age, etc. What about the meta-analysis that we have in the field of adjuvants? Well, the meta-analyses are not so consistent here in the adjuvant setting. In fact, it seems that adjuvant treatment with cisplatin-based chemotherapy is offering for an impact in disease-free survival. But take a look at the last part. Take a look here. It is, how we say in statistics, it is touching the 1. So, well, probably it is impacting in disease-free survival, but definitely it is not impacting in overall survival. There are other meta-analyses saying the opposite. I think it is just a matter of, well, how these adjuvant trials were designed, how was the follow-up of these patients, if this was a formal follow-up, if it was just retrospective analysis. I think if you didn't give because of the reason that you want, If you didn't give neoadjuvant treatment to a patient with maxillary invasive stage, well, probably adjuvant treatment should be considered as a cystectomy too. What are the European Association of Urology guidelines are saying? Well, if patients have not received a neoadjuvant approach before, adjuvant treatment based on cisplatin, once again, based on cisplatin, should be offered for patients with PT3, PT4, or lymph nodes involvement. Once again, immunotherapy should not be offered to these kind of patients as an adjuvant treatment. What are the advantages and disadvantages of the adjuvant versus the neoadjuvant? Okay. Probably if I were a urologist, I would say exactly like this. Advantages of the adjuvant study. Well, cystectomy is done immediately, and of course, I agree with you that well, the removal, the resection of the bladder probably is curing the majority of the patients. And with the chemotherapy, you are going to cure only 1 out of 12 patients. Yes, that's right. So cystectomy is not under danger, so you can do the cystectomy and probably cure your patients. Of course, the pathological stage is much more accurate if you are removing the bladder than if you are only, well, doing a clinical assessment or imaging assessment. In the pathology report, you have a deep analysis of the invasion of the bladder, you have a deep analysis of the lymph nodes involved. And of course, this is not easy in the neoadjuvant setting, well, to analyze the pathology report of the bladder as far as probably the tumor has disappeared, and probably this is not easy for the pathologist to do a very accurate report. Which are the most important disadvantages? Well, complications of the surgery, and all surgeons in the world have some complications, well, may delay or even may avoid the use of chemotherapy after the treatment. Of course, if you are offering for a highly pancytopenic agents like cystectomy regimens, well, you can induce thrombopenia that can interfere with the scar and can interfere with the surgery. You can induce neutropenia, more infections, and of course you can induce anemia, and of course there could be a deterioration in the performance status of the patient. So all of these things need to be taken into consideration. 2 last slides. As a summary, well, this is a very challenging field, very challenging field. You have seen the evidence behind the use of neoadjuvant chemotherapy and behind the use of adjuvant chemotherapy. And you know in the real practice, in your environment, with your urologist, with your oncologist, you know how the debate it is. The thing is, and the facts are, around 50% of the patients, they have a T3 or T4 or lymph nodes positive, and they are relapsing after the cystectomy, after the surgery. So half of the patients will not be cured with the resection only. Around 12 to 13% of patients with maxillary invasive bladder cancer undergoing radical cystectomy are receiving neoadjuvant setting, neoadjuvant treatment in the real practice. These numbers are probably increasing, but they are less always than 20% of the patients. So the majority of the physicians, the majority of the urologists, the majority of the oncologists in the real practice are not following the guidelines. Around 50 patients who receive neoadjuvant chemotherapy have received high-risk disease, and the survival of these patients normally is less than 4 years. So the majority of these patients will relapse locally or in a distant manner. And 50% of the patients are ineligible to receive cisplatin. So forget about what we said about the meta-analysis in the neoadjuvant setting and in the adjuvant setting. These patients are not good candidates to receive perioperative chemotherapy, and the prognosis of these patients will depend only on the cystectomy. So it means that the majority of the patients, at least half of the patients, will not be good candidates to receive perioperative chemotherapy impacting in the survival. So the multidisciplinary team is key, and I would say it should be mandatory. Of course, in a well-developed country like France, this is something that probably you have heard many times and you are doing routinely in your clinic. But in countries like Spain, I promise, there are a lot of hospitals, and I'm not referring to the community hospitals only. There are a lot of big hospitals in which decisions are taken by only one guy in the multidisciplinary team. And I think we should all work together. I think this is important. Well, thank you so much. So, Dr. Bossi, should I move on to the next presentation?
Well,
immunotherapy in this field?
Probably if you have some burning question, I would
Of course.
take them now, because I guess this is a very important topic for all the oncological community treating bladder cancer. So you have questions, comments, what's your own experience? Because as Enrique told us very clearly, there are probably regional differences in how neoadjuvant protocols are applied before cystectomy for bladder cancer. So what's your experience, for example, in Belgium or Italy, or where do you come from? Belgium, for example, I will ask you directly. Do you have an idea on how frequently neoadjuvant protocols are proposed before cystectomy?
Usually, mostly we propose neoadjuvant chemotherapy. It's our standard.
Okay.
Belgium. Yeah. But I don't have
The number.
The number.
In Italy too, you have the feeling that this is proposed?
Yes, it's proposed. Not that often, as I can see, but it's proposed. And recently, it's more often, it's getting more often. And sometimes after the neoadjuvant, in some selected patients, we practice the partial cystectomy, not radical cystectomy. I don't know.
Could you hear, Enrique?
This is very, very slow, very low volume.
There was this.
I was telling that sometimes in some selected patients after the neoadjuvant, we also have done a partial cystectomy, and there are very few patients, but until now we have good results. Very localized, how can I say, T2 bladder cancer. I don't know if it's so safe. We just tried in 2 or 3 patients.
It's about in those patients in which you already give neoadjuvant treatment,
yes,
followed by cystectomy, partial cystectomy.
Yes.
If adjuvant treatment after the surgery is feasible and we should give it or not.
Yes.
Is that the question?
Yes, let's say is that the question.
There's a huge debate about it. And the response, the official response, is that no, you should not give adjuvant treatment after neoadjuvant approach. This is the official response. However, as you said, if one by one, if you are discussing in your multidisciplinary team and you are discussing with the patient which is the risk, especially in those patients in which you, with the neoadjuvant approach, you got a tumor shrinkage, but not a pathological response, these are the best scenario to offer for adjuvant treatment later. Why I'm saying that? I think it doesn't really make any sense to use adjuvant treatment in patients who achieve a pathological complete response. And same, it doesn't make any sense for me to do an adjuvant treatment in patients who didn't respond to initial chemotherapy in the neoadjuvant approach. My only patient profile in which I will discuss case by case with the patient and into the multidisciplinary team would be those patients. Imagine that you have a PT3 according to the, well, a T3 according to the MRI or according to the TAC or according to the pathology stage, and you have a T2 after the cystectomy. So in these patients, you had a tumor shrinkage, but probably this patient is not yet cured. So probably 3 cycles after the cystectomy could be an option to discuss. But this is not a standard. That's a great question.
We had several cases of complete response after neoadjuvant chemotherapy. So I don't know, can we think of delaying the cystectomy?
So the question, Enrique, is about complete responders after neoadjuvant chemotherapy. And this is a very important question. I will also add something. So in this case, may you consider postponing this radical cystectomy?
But should we do a cystoscopy after chemotherapy?
Definitely not. Definitely not. Don't forget that the curation of the patient is coming from the surgery. I am, despite I'm an oncologist, I realize that the only guy that is curing my patients is my urologist, not me. So despite of the complete response, you need to operate the patients. Of course, once again, case by case, you can discuss with the patient. The patient is refusing the cystectomy. The comorbidities of the patients is not making feasible to do the operation. But as far as you need a cisplatin eligible patient to receive neoadjuvant treatment, these kind of patients that are not good candidates for cystectomy, these are very few in the clinic. The only thing is that patients that are refusing the cystectomy. But patients refusing cystectomy, be careful because this is not the standard of care and probably the tumor will relapse.
So if I may, this is an important question you make because we see, you know, I'm a radiotherapist doing GU cancer, and we see more and more patients who were scheduled for neoadjuvant chemotherapy before radical cystectomy and having a complete response after neoadjuvant chemotherapy, they don't want cystectomy anymore. And they come to us for second opinion, telling us, everything is done by chemotherapy. We want now a blood-sparing approach. So this is real life scenario, I'm telling you. And I have to admit, I would like to have your opinion, but I have to admit that I don't like this very much because I don't like to change, during the journey of the treatment, to change your indication like this. I guess that the good responders is a very good prognostic factors, but should not give us the possibility to change our treatment. What do you think?
Absolutely. Why it is extremely important to work together into the multidisciplinary team. This is why we should discuss case by case because patients are completely different one to the other. Patient preference, we need to ask our patients what do they prefer. And we need to treat the patients according to many factors, not only what the guidelines are saying, not only what the evidence is saying, but also according to the patient preference and experience of the institution. Probably Dr. Bossi, you are an expert, a real worldwide expert in the field, but not all your colleagues feel comfortable doing radiation to the bladder. Not many of your colleagues.
Correct.
They prefer to irradiate the prostate, they prefer to irradiate the rectum, but not really the bladder. Why? You know more than me. But this is something that we need to discuss, and we need to create evidence to do that.
Correct. Yeah. Try
think
to
there is-
show up otherwise.
I think there is long debate between the neoadjuvant chemotherapy between the doctors. There is doctors with the chemotherapy, there is another doctor against the chemotherapy. Even if you see the guidelines of European, they said you have to propose the chemotherapy for the patient fit for the chemotherapy. When you discuss with the oncologist, what's the mean fit? Okay, there is a lot of oncologists. They said, okay, the fit's it's the creatinine and the function, renal function. Okay, other they said no, the age of patient and comorbidity. There is I don't know what's the mean fit for the chemotherapy.
That's a great question. We will discuss that in the metastatic stage, okay? Because to consider a patient eligible or ineligible for cisplatin, we normally are using the Galsky criteria, including creatinine clearance, including ECOG performance status, hearing loss, neuropathy, and cardiovascular history of the patient, you know? But in addition to Galsky criteria, we have many other factors that are influencing. In reality, people in the practice, in the metastatic setting, are using more carboplatin than cisplatin. They are using carboplatin in patients eligible for cisplatin. And this is because of any reason, because of factors, clinical factors, or analytical factors that are beyond the Galsky criteria. In the early stages, in the neoadjuvant approach, we should not use carboplatin. The guidelines are recommending to treat patients perioperatively only with cisplatin-based chemotherapy. Despite of that, many colleagues are using carbo-gem to treat patients in the neoadjuvant setting and in the adjuvant setting. And well, this is not what the guidelines are saying, but once again, this is a one-to-one discussion, this is a multidisciplinary team discussion, and we need to adapt the tools that we have, but always taking into consideration the guidelines, taking into consideration the evidence that we have. And don't believe me when I'm saying that this field is going to be more and more exciting in the future when immunotherapy is coming. Because immunotherapy doesn't understand about eligibility for cisplatin or not, and immunotherapy can potentiate the radiotherapy, and probably a lot of patients could be rescued with these combination approaches. We will see.
Just a question, Enrique, because I will not touch the field of post-op radiotherapy. You know that there are some colleagues, especially in the Belgian area, which are advocating post-operative radiotherapy for patients presenting with high-risk disease. What's your opinion on that? I have my opinion, but I would like to have yours.
No, you know much more than me, but what I can tell you is what we are discussing into our multidisciplinary team when we are using post-operative radiotherapy is in those patients with PT4. Those patients with PT4, we are routinely recommending radiotherapy after the cystectomy. But I will be listening to your talk because probably you will say more than me.
Okay. If we don't have any other comments or questions, shall we move to the second part of your talk?
Okay, immunotherapy, and now the thing is changing, and now, well, probably you will see something different or something new or something promising in this field. I think you will like it. Well, first, take into consideration that the median age at diagnosis of patients with muscle invasive stage ranges around 70 plus years. So it means these patients normally have a lot of comorbidities and a lot of co-medications to offer. So normally these patients are frail patients, or at least, if not frail, they are patients in which we cannot give for cisplatin-based chemotherapy. So this is a real unmet need that we have in the clinic. And this is why it is extremely good that novel agents like immunotherapy, which are normally well tolerated and which can induce some tumor responses, are very welcome in this field. Okay, so let's focus on the neoadjuvant treatment with immunotherapy. You saw this graph before, and I think it is important to think twice about this graph. Despite of NCCN guidelines, ESMO guidelines, EAU guidelines are recommending neoadjuvant treatment, the real world is saying that only less than 20% of patients are finally offered for neoadjuvant approach in the daily practice. And this has a reason. And the reason is because of, well, my patient is not fit enough, is not eligible to receive cisplatin. And this concept of being fit or this concept of being eligible is beyond the Galsky criteria. In the real practice, being eligible for cisplatin means that you need a patient in a good shape, with a good performance status, with very good kidney function, and at least in Spain, it is not easy to find these kind of guys because of the high percentage of patients with diabetes that we have impacting in the kidney function. And this is also, we have one of the highest rate of hepatitis. So probably the metabolism of the patient is not the ideal one when our patients have 70 or plus years old. These are the real cases that we have. Okay, can we use immunotherapy? Can we treat those patients ineligible to receive cisplatin? Can we treat them with immunotherapy single agent? Well, there are two brilliant trials, the two first ones that are impressive. A very friend of mine, Andrea Necchi, published and did several publications. Last week, he did the latest one talking about the overall survival, about the PURE-01 trial with pembrolizumab. Pembrolizumab, is a PD-1 inhibitor. It's one of the most known immunotherapy that we have. And this Italian group offered for 3 cycles of pembrolizumab before the radical cystectomy to patients with T2, T3, or T4. Pathological complete response was the primary endpoint. And take a look at the data, because I think these data are impressive. In those patients, in the 50 cases that were treated, 42% of pathological complete responses were achieved with pembrolizumab. 42%. Remember the figures we saw before with chemotherapy, ranging in between 25 to 50. So the data of pembro alone are not so less than the pathological complete response we can expect with chemotherapy. And one additional thing, those patients that are receiving cisplatin-based chemotherapy, ranging a pathological complete response in between 25 and 50%, are patients eligible to receive cisplatin. So it means with a better prognosis than those patients ineligible for cisplatin like this one. In addition to that, in those patients with PD-L1 positive, well, the pathological complete responses went up to 54%. 54%. So this is in the upper range of the activity we can expect with chemotherapy. So I think these data are impressive. And Andrea Necchi and his group went a little bit further, and they did several immune signatures. When I say immune signatures, means that they are taking gene signatures and they are assessing how is the expression of different genes involved in the regulation of the immune system, especially a gene signature affecting interferon alpha, interferon gamma, inflammatory response in general, and this immune signature of something like 20-something genes related with the immune system. And as you can see here, those patients in the dark blue that you have here are those patients that are achieving a complete response. Especially, take a look at those genes related with interferon gamma. Those patients with high regulation of the interferon gamma gene, they are the ones with the highest chances to induce a pathological complete response. So this is extremely promising, because the question is, can we select in advance which are the patients that will respond to immunotherapy as a single agent? Because probably these patients with activation of the immune interferon gamma signature, probably these patients are the best candidates to receive these kind of approaches. We have a second phase 2 trial, the Abacus trial. Well, Andrea Necchi did it great with pembrolizumab, but Tom Poles did it even better with atezolizumab. Why I'm saying that is because, Andrea Necchi published a couple of papers, 3-4 papers, but Tom Poles has published a Nature Medicine paper with this trial. Atezolizumab as a single agent, only 2 cycles before the cystectomy, was offered as a neoadjuvant approach. Once again, pathological complete response was the primary endpoint. And one thing coming from this trial that I think it is important, you can see that in this slide. Pathological complete responses were higher in those patients with a lower T stage. So it means those patients with T2 were responding more than those patients with T3 or T4. Pathological complete responses in patients with T2 was up to 35%. Pathological complete responses in patients with huge tumors, in T3 or T4 tumors, were only 15%. This is important for the clinic. We can clinically select patients. The pathological complete responses in patients with PD-L1 positive with atezolizumab was 37%, and in patients with PD-L1 negative, 24%. And it seems that it could be translated into an improvement in overall survival. It seems. Of course, this is not statistically significant. Of course, this is not a randomized trial. This is a prospective trial, only one arm. But take a look at the graphs, because I think these complete responses, pathological complete responses, could be translated into an improvement in overall survival. In addition to that, in the publication in Nature Medicine, we can see that the infiltration of lymphocytes, the infiltration of CD8 is also correlated with the activity of the medication, of the immunotherapy. Those with high infiltration of the tumor by lymphocyte, by CD8, you can see that the pathological complete responses were 40% versus 19% in those patients with lower lymphocyte infiltration of the tumor. And take a look at the graph for the survival. Those patients with lymphocyte infiltration are living longer when treated with atezolizumab than those patients without such infiltration. And tumor mutational burden. Well, pembrolizumab is approved in an agnostic way, so it means that all tumors, all solid tumors with high tumor mutational burden can receive, according to the FDA, pembrolizumab treatment. Okay, in the neoadjuvant setting, only taking into consideration the mutational tumor burden, it seems that the activity of atezolizumab doesn't make any difference. 31% in those patients with high mutational tumor burden, and 27% of complete response rates, complete pathological complete responses in patients with lower mutational tumor burden. So it seems that at least in the neoadjuvant setting, mutational tumor burden is not the best biomarker we can have to select patients. Okay, this is a summary of, to my knowledge, all the phase 2 trials reported so far in the field of urothelial tumors up to ASCO, and this is what it was presented at ASCO. Well, take a look. We have commented the PURE-01 with Pembro, the Abacus trial with atezolizumab. This is an MD Anderson in Houston experience with the combination of durvalumab and pembrolizumab. The Nabucco trial used nivolumab ipilimumab, so PD-1 plus CTLA-4, PD-L1 and CTLA-4 for durvalumab tremelimumab. BLAST2 with durvalumab single agent, BLAST1 combining cisplatin gem plus nivolumab. At ASCO, I had the opportunity to present the data of the Deuteranol trial with durvalumab tremelimumab. We will talk in deep about it. And there were a couple of cooperative group trials combining chemotherapy, this plus pembro, or gemcitabine only plus pembro. But take a look at the small sample size that we have. Take a look at the differences in the inclusion criteria, including patients eligible and ineligible, only ineligible, or who are refusing the patient the chemotherapy, ineligible or refusing chemotherapy, eligible for cisplatin, so different prognosis, cisplatin eligible and cisplatin ineligible. And as a summary, the pathological complete responses we can expect with immunotherapy alone is in the range of 40%. And another thing, if we are combining chemo plus immuno, the response rate seems a little bit better, but not dramatically different. 49% with cisgem nivolumab, 44% with cisgem and pembro. So it seems it's could be a little bit higher, but it doesn't really seem this is synergistic chemo plus immuno in this field. If we are focusing only on patients with PD-L1 positive tumors, the pathological complete responses goes up to almost 50-something, 60% of the patients. So we can have a biomarker. We can select patients molecularly to receive this kind of approaches with immunotherapy-based combinations or strategies. Let me go a little bit in deep about the DUCHA trial that I had the opportunity to present at ASCO. And well, I'm proud of this trial, and I'm proud because, well, I had the opportunity to lead the trial, but I enjoyed a lot doing this trial, and we are still recruiting patients for the trial. Patients with urothelial tumors, with muscle invasive urothelial tumors, T2, T3, T4, were selected for being recruited in this trial. And in the first biopsy that the urologists were taking in the first transurethral resection, we did central tumor inflammation signature analysis. Once again, we had an inflammation signature. It was a nanostring formally assessed and formally authorized by the FDA inflammation signature, and we classified patients according to this objective gene signature in patients that were cold or desert for immuno-oncology related genes, or hot or inflamed tumors. This is the spectrum that you may have. So these patients in blue in the signature are those patients that are expressing in a lower manner these genes related with the inflammation. Those patients in red, orange are those patients overexpressing genes related with the inflammation. So patients in this side will be hot or inflamed tumors, and patients with tumors in this side will be patients with cold or desert. Okay, according to the results of the signature, those patients that are cold, well, normally you are not expecting a good response with immunotherapy. So these patients with cold tumors were receiving a standard cisplatin-based chemotherapy, while those patients with hot or inflamed tumors were prospectively randomized to receive a standard chemotherapy based on cisplatin or the combination of durvalumab and pembrolizumab. All patients were followed by radical cystectomy according to the standard. Okay, why we did this trial and why we tried to select patients in advance according to the expression of different genes? This is the reason. Those patients with PD-L1 are doing better with durvalumab, at least in the metastatic stage. Those patients with interferon gamma gene-related signature are doing better, at least in the metastatic stage. So we said, okay, at this point, this was immunohistochemistry approach. So it was the pathologist, and with the bias of the pathologist and with the perception of the pathologist, was the one classifying patients as PD-L1 positive, PD-L1 negative, as interferon gamma positive, interferon gamma negative. So what does it mean? It means that probably, when we were needing for a more accurate, more objective way to assess patients and to classify patients. And this is why we chose the nanostring technology, the nanostring tumor inflammation signature. Another discussion that we have is where is the threshold? What is the threshold? Where is the limit in the immune signature? Because the immune signature is not positive or negative. The immune signature is giving you a score. So, we decided to put this threshold. So the lower 1/3 were considered cold, and the upper 2/3 in terms of expression of gene related with inflammation were considered hot. Okay, you can see the distribution of the patients in these small black points you can see down here. So, the majority of the patients were hot or inflamed tumors, and few patients were cold or desert tumors. Okay, first, we are going to focus on the combination of the comparison of the durvalumab versus standard chemotherapy. In yellow, you can see the toxicity of the immunotherapy. In gray and orange, you can see the toxicity of the two arms with chemotherapy. So it is very easy to see that immunotherapy is much better tolerated than chemotherapy. No doubt at all. Immunotherapy is better tolerated than chemotherapy. This is the first message. Second message, activity. Selecting patients with tumors that are desert or cold for the immune system is making that the immunotherapy, the chemotherapy in the cold arm, standard chemotherapy, is offering for a pathological complete responses of almost 70%, which is higher than expected with the series we saw before. Don't forget, once again, expected median pathological complete responses were ranging in between 25 up to 50%. And now you can see almost 70% pathological complete responses. And what did happen in patients in the hot arm, in patients with tumors that are inflamed? Well, responses were much, much lower in the chemotherapy arm, 36% versus 68%. But take a look, there was not a significant difference in terms of activity, in terms of pathological complete responses in those patients who received chemo versus those patients who received the combination of durvalumab and tremelimumab. Same happened in those patients with pathological downstaging, no matter which level of pathological downstaging we have. So it seems that in those patients with hot or inflamed tumors, the use of immunotherapy may be translated into a similar efficacy with a better safety profile. One of the questions after seeing those results that we have is, maybe we did it wrong with the threshold. I mean, when we use lower 1/3 for those to classify patients as desert or cold tumors, and upper 2/3 to classify patients as hot or inflamed tumors. Well, unfortunately not. Unfortunately, the tumor inflammation signature is not really working at all. Why I'm saying that? Take a look in the green dots. You can see the pathological complete responses we got with chemo in the cold arm and in the hot arm. As you can see pathological complete responses spread across all the tumor inflammation signature score. So it means it doesn't matter if the patient has a cold or desert tumor or hot tumor, the chemotherapy is working exactly the same, a little bit better in those patients with cold tumors. However, in the immunotherapy arm, those patients with durvalumab and tremelimumab, and once again the green dots are meaning the pathological complete responses we observe, you can see pathological complete responses. And don't forget that all of these patients were classified as hot, so all of these patients, they have tumor inflammation signature scoring in the medium third or in the upper third. So it means that the threshold we use is good enough or not as good as we wanted, and the tumor inflammation signature is not really a good classifier of patients for response to immunotherapy. What else we observe? Importantly, PD-L1 expression. Probably PD-L1, according to the pathologist report, is a better biomarker that can predict activity for the immunotherapy in the neoadjuvant setting. Take a look at the pathological complete responses with durvalumab and tremelimumab in those patients with PD-L1 positive, 57%, versus those patients with PD-L1 negative, 14%. And this is something that we didn't observe such difference when we use chemotherapy, at least in the hot or inflamed arm. But take a look at those patients in the cold chemo arm, those patients with PD-L1 negative, they showed highest pathological complete responses, up to 90% of pathological complete responses with cisplatin-based chemotherapy. So it means that maybe we were wrong. Maybe selecting patients according only to the PD-L1 expression, maybe we could have done a better selection of the patients. And what about histology? Because we are always referring to urothelial histologies, responses of immunotherapy in urothelial histologies, responses of chemotherapy in urothelial histologies. Take a look at what we observe in those patients with variants from urothelial tumors. We didn't observe any patient responding to immunotherapy with variants histologies. This is, of course, a subgroup analysis, and of course, this is just hypothesis generating, but take a look at the chemotherapy. The chemotherapy, it seems to work better in those patients with variant histologies rather than in urothelial histologies, at least with hot tumors. And finally, take a look at the data coming from the Nabucco trial. The Nabucco trial, phase 2, single arm, not randomized trial, using doublets of immunotherapy, the combination of ipilimumab and nivolumab. Unfortunately, we didn't have this data before conducting and before designing the deuterium trial. Why am I saying that? Well, this is the same tumor inflammation signature we use to select prospectively our patients in the deuterium trial. And as you can see, no difference at all in terms of responses, in terms of pathological complete responses with nivolumab, ipilimumab, when used this nanostring tumor inflammation signature. However, take a look at the difference in terms of activity when used the interferon gamma as a positive biomarker for the activity of immunotherapy. And take a look, and this is very important and probably will be relevant in the future. Take a look at the activity of TGF-beta, the activity of the durvalumab tremelimumab in those patients with high TGF-beta. TGF-beta is a negative factor, is a negative biomarker, is predicting for lack of activity. So it is as relevant as to have a good biomarker than a conditioning marker for non-prognosis. This is my last slide, and this is what it is coming with immunotherapy in the field of neoadjuvant tumors. Take a look at these 4 trials. I think it is important to have into consideration these pembrolizumab-based combination trials for patients that are ineligible for cisplatin or eligible for cisplatin. This would be extremely interesting to see that. The Checkmate 078 trial is comparing the activity of chemotherapy versus the combination of chemotherapy plus nivo plus another agent. And the Niagara trial is combining chemotherapy plus durvalumab. And take a look, after the cystectomy, they are doing a maintenance therapy, or they are doing an adjuvant treatment, maintaining durvalumab in this setting. So we will enjoy a lot in the future. We will need to define good biomarkers in the future to select the best patients to receive these kind of approaches. Thank you very much.
Thank you, Enrique.
Side of surgery, and so in terms of overall survival, surgery better than radiotherapy alone. Third, if I may, take-home message. Radiotherapy alone is certainly not a good choice for your patients. Okay. This does not mean that we may identify a subgroup of patients which are generally palliative cases in which radiotherapy alone may be useful. What is the most clearly profile of those? Patients having grossly hematuria, which is not controlled by any other kind of intervention. Palliative radiotherapy in this case, radiotherapy alone, is very useful. 2 sessions, 6 gray in 2 sessions, and you have 75% chance of stopping the hematuria. No more transfusion for this guy. You will not impact on his quality of life, apart from, of course, the transfusion. You will not impact on his quantity of life, overall survival, but from the palliative point of view, I think this is still an important success. We are not talking about this kind of radiotherapy here. We are talking about the ambition of curing patients. Radiotherapy alone, certainly inferior as compared to surgery. And indeed, as we are in a teaching course, I guess it's important for you to always refer to guidelines that have been put together by important people, knowing this much more than I do. Do not offer radiotherapy alone as primary therapy for localized bladder cancer. You know why now. Okay. Strong recommendation. UDOU 2020. I will go back to this UDOU recommendation later on. I will just notice for your information, these are the panel of colleagues that are responsible in the frame of the UDOU for the bladder committee. I know a couple of those. You probably also know a couple of those. Which is, I know, Camperat, French. There is not a radiotherapist. Okay. We will come back to this. Don't forget it. Why the idea of adding chemotherapy to radiotherapy? Well, first of all, because the result of radiotherapy alone are really, as I showed you, poor. But also because at that time, when trimodality and so radio chemo protocol was proposed, we knew already that chemotherapy alone, at that time, MVAC for metastatic patients, had some effect on bladder cancer. And especially we knew that chemotherapy could work as a radiosensitizer for radiotherapy. We had the example of the analogy with other cancers, like anal cancer, head and neck cancer, in which we may do today what we called organ sparing protocol. So we don't oblige all patients with anal cancer to have a pouch. We don't oblige all patients with larynx cancer nowadays to get their larynx out, because radiotherapy plus chemotherapy, and chemotherapy may have a radiosensitizing effect. So all these reasons have prompted the idea of associating radiotherapy and chemotherapy to obtain better result than radiotherapy alone. And we had, in the radiotherapy community at first, randomized trial, showing that indeed chemoradiotherapy was superior to radiotherapy alone. Of course, now you have seen the UDOU guidelines last year, they will confirm that, but at that time we were not aware of this. Look, Peter Hoskin, JCO 2011, a group of patients treated at that time with a very peculiar British, if you want, protocol with carbogen and nicotinamide, very complicated setting for treating those patients, something much more, if you want, reproducible in other trials using cisplatinum. And we are back with the concept that has already been elegantly shown you by Enrique, the importance of using cisplatinum in this setting. And other that have proposed 5-FU and mitomycin C. We will see it later on. A local control benefit, statistically speaking, very clear one. You control the disease better if you take advantage from the radiosensitizing effect of chemotherapy together with radiotherapy. And also a borderline benefit in terms of overall survival, which is not bad. Of course, patients are asking to live longer. This is the English experience. You are probably aware, and you know this name, Nick James. It's a radiation oncologist, nowadays in London. At that time, he was somewhere else. Radiotherapy alone versus radiochemotherapy. Those data have been very recently updated with a longer follow-up. Next slide, you will see that. But this was his idea. We will use 5-FU and mitomycin C that are probably even more active than all cisplatinum-based chemotherapy. 360 patients, a local control which is statistically significant better by radiochemotherapy as compared to radiotherapy alone. Acute late effect. Acutely, the toxicity is enhanced by using chemotherapy, but in the longer term, no difference in terms of side effects. And this is a quite important message for our patients. You are suffering now, but overall survival is better, local control is better, and in the long run, toxicity is not enhanced as compared to radiotherapy alone. This is the last update of this trial, British trial by Nick James, T2, T4 cancer, radiotherapy, 5-FU, mitomycin C, radiotherapy alone. The results in terms of overall survival, which are statistically, let's say, borderline. There is a nice diversion of the curves, but not statistically significant. No doubt that in terms of local regional disease-free survival and specific disease-free survival, radiotherapy plus chemotherapy is better. For the radiotherapist in the room, I guess there is only one, if he's still here, it's probably interesting to notice what kind of radiotherapy was applied in those patients. The concept of dose, it's, as you know, a very important one for radiotherapy. The concept of which fraction is chosen is also a very important one for radiotherapy. And you see that they would use a very classical 64 gray in 32 fraction, so 2 gray per fraction, or what we call nowadays an hypofractionated scheme of 55 gray in 20 fraction. Okay? So 2.75 gray per fraction. Both were used in the trial. These results are now updated at 70-month follow-up, so they're quite solid. Okay. 5-FU mitomycin C, I told you, were very specifically introduced by Nick James' group. But before that, if you look to the historical series of 3-modality therapy, and you have here a group of those, you don't have the year when this was published, but believe me, this goes back in the early years of this century. Cisplatin was always present, or alone, or associated with 5-FU. So a third or fourth take-home message will be that cisplatin seems to be also quite essential in this indication, apart from the British experience in which 5-FU and mitomycin C were used. At this point of my presentation, I'm sure you are very enthusiastic about this idea of putting together radiotherapy and chemotherapy for bladder cancer. The real question is this approach valid for all comers, all patients diagnosed with bladder cancer? No. Nick James immediately identified patients which are unsuitable for bladder-sparing approach. Of course, we had the experience, I've told you, about radiotherapy alone, which was already important. And some factors in this list are already known from the first list I showed you. But there is the first one, which Morgan Rupré was alluding earlier this afternoon. Do you remember what he said? Yes, about the idea that if you want to spare an organ, you should start with an organ that works well. There is no point in sparing a bladder which is not working well. So Nick James, number one, selection criteria for 3-modality therapy, poor bladder or renal function, as you mentioned. Why poor bladder? No hope with radiochemotherapy to make a bladder work better if you start with a patient who has a poor bladder function. Okay? Second point, highly symptomatic bladders. Again, We are exactly in the same kind of situation. No point in sparing a bladder which works insufficiently good. Hydronephrosis, do you remember? Extensive CIS component. Sorry? We have always seen in all series of radiochemotherapy that those patients were doing less well, probably because extensive CIS indicate a disease which is all over the place, too big to be controlled by radiotherapy. Multifocality. Prior pelvic radiotherapy, of course. Inflammatory bowel disease, because it's difficult to give new radiotherapy if you have already been irradiated into the pelvis. Fifth take-home message, probably the second more important one. Chemoradiotherapy protocols could not be proposed to all comers, but only to a very selected population of patients, and this selection should be done by the surgeon and the radiotherapist and the medical oncologist. It's not the radiotherapy alone, the radiotherapist alone that will make this selection of patients. This is a so important concept that the team that is from the Massachusetts General Hospital, William Shipley, the last author of this publication, the team has had more experience in the States on bladder-sparing protocols, has even produced a sort of nomogram. You know what nomogram are. You put together different prognostic factors to identify blah, blah. What they've done, they have proposed this nomogram, 2013, taking into account some of those factors that I've listed in order to identify patients potentially being as best candidates for bladder-sparing protocols. At the end of the day, you have this sort of clear-cut slide that I would like you to bring home. Ideal candidates are on the left-hand side. No hydronephrosis, no CIS, complete TURB, unifocal tumor, good bladder function and capacity. And the poorer candidates are on the right-hand side. Why this is so important? Because if you see a series of patients treated with radiochemotherapy in a bladder-sparing protocol, which pertains to the list on your right-hand side here, you immediately can check that this was not a good choice for them. Surgery would have certainly, perhaps with neoadjuvant chemotherapy, better served them. Okay. And this without even jumping to the result pages of your article, just by watching this. In terms of what kind of flowchart of strategy have been proposed for those patients, Massachusetts General Hospital, as I told you, in Boston, probably one of the biggest experience in the world in treating patients with bladder-sparing protocol. They had a very clear-cut strategy which needed to repeat a cystoscopy and biopsy somewhere in the middle of the radiotherapy course. The idea being, in this respect, that the first part of your radiotherapy would help you selecting patients which are good responders, and so you may go on with the treatment till the end. But if the disease has not responded correctly at some midterm analysis, it's useless to go on. Let's go for radical cystectomy plus or minus neoadjuvant chemotherapy. So the concept of Massachusetts General Hospital protocol is a concept in which at a certain point of the treatment, of the radiochemotherapy treatment, you take a pause, you reanalyze the answer you got, and you go on if this is good responders or not. What is the requirement behind such a strategy? A very, very clear cooperation between surgeons, urologists, and radiotherapists. Because you don't want to spend months to wait for this TURP and biopsy result. Because if you spend months for waiting for this, your patient is lost. So you have, again, as I told you as my first take-home message, you have to have a very, very close cooperation with the surgeon to make this go very swiftly. Do you agree? This was much less possible in Europe. With the team of Nick James, the team of Erlangen in German, Rödel, has published a lot on this, and they have a totally different approach. They cannot permit to have this sort of midway re-evaluation of the response, and so they say, no, 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 we go straight on and we do. Once you had a complete TURP, you remember the three elements we have to have. After complete TURP, we go until the end with our radiochemotherapy program. And they have published their results. Astonishingly, the result of the two groups, of the two strategies, are not very different. Look at that. These are the results published on European Urology 2012 by the Massachusetts group. First, these are cohort studies. No any sort of randomization, nothing. Just a series of patients that were treated more or less in the same way. First things to notice. Look here, 16% had hydronephrosis. One patient out of 4 had CIS. So you know that those are poor candidates. Why are they here? Because in the real life, you have patients refusing cystectomy, patients to which you tell, listen, gentlemen, radiochemotherapy is not good for you. No way. I don't want nothing else. And so you treat them. Okay. But you have to take into account that these were probably not the best candidate for this approach. Very easy to remind what kind of results are there. In terms of overall survival, 5-year, 50%. 50% are alive at 5 years. And second result, in this series of patients, 80% of those alive at 5 years have retained their native bladder. Overall survival, 50% at 5 years, 80% of those have their native bladder. The other one, the European one, again, these are data which Rödel published in 2002. I know that he wants to update those data, but that's what we have. Patients with CIS, 20%. Even CN plus patients. T4, hydronephrosis was not evaluated. The results are the same. Look, more or less 5 years, 50% overall survival, 80% at 5 years with their bladder. And now the big question. Are those results comparable, worse, or better as compared to surgery? Question mark. And now I want you to answer. So this is a European urology publication from the group of Massachusetts General Hospital. They have compared here some 5-year and 10-year overall survival data coming from radical cystectomy, radiochemotherapy, or vice versa? Could anyone here in the room tell me which one pertains to radiotherapy and chemotherapy and which one pertains to surgery in terms of overall survival? If you believe that overall survival is a good endpoint of those patients, do you have strong feelings? Yeah, the three first are radiochemotherapy because they are doing worse than the others, or the vice versa. In other words, can you only based on overall survival result identify which were treated with what? I don't think so. And indeed, the three first were from cystectomy series, Memorial Sloan Kettering, the SWOG group, and the other, again, University of Erlangen, MGS, RTOG, and the British one. Okay. You know my conclusion, but of course I'm biased because I'm a radiotherapist. And indeed, the European Association of Urology, looking at this result, even if any radiotherapy was involved in the panel, could not conclude in a different way by saying 2020, in a highly selected patient population, long-term survival rates of multimodal treatment are comparable to those of early cystectomy. I have to admit two things. First, if you look what we are doing currently for those patients, okay, even if we had those sort of data, and we have these nice comparative studies based on the National Cancer Database, in which from 98 out to 2010, you see they've checked what kind of therapy was offered to bladder cancer patients. So I'm looking to the green bar here. I have to admit that this has not moved that much, okay? And don't forget here, we were doing radiotherapy alone. Only here, radiotherapy was supplemented in a very clear cut fashion with chemotherapy. And even if you look to the mortality rates after local treatment, of course, if you do nothing and the treatment reference is cystectomy, well, this gives you a 2.4 hazard ratio likelihood of dying as compared to patients who had cystectomy. But if you look to chemoradiotherapy, this is not significant. So it's not only the result I showed, which are, in my opinion, so good with chemoradiotherapy, only for bigger institutions, Memorial Sloan Kettering, Massachusetts General Hospital, or experienced people like Nick James or the colleague in Erlangen. No, these are community-based hospitals in the States giving their data for the National Cancer Database. Of course, radiochemotherapy is toxic. It's a toxic treatment, and patients should be aware of that. They should be aware that this is a toxic treatment. Again, the German here, they had some grade 2 toxicity, we can imagine, not that important, but they also need salvage cystectomy in 2% of their patients. They had bowel obstruction requiring surgical intervention in 1.5 patients. So far from me the idea of telling my patient radiochemotherapy is not toxic at all. It is. It may be toxic. And in terms of toxicity of radiotherapy, I know that this toxicity here is certainly enhanced by bad techniques. 3D conformer as compared to IMRT that we may do today. I'm not going into details of techniques because I don't think this is the most important message today, but don't forget this. And again, if you look to the experience at the States, Mass General Hospital, the same data there with some toxicity. But my last point is this one. So we ask ourselves, and it seems that all multidisciplinary tumor board, when discussing a bladder patient, will discuss this question. Is surgery better than radiotherapy for local control? I will propose you what Nick James says about this. He says, this is probably not the good question. This is not the good question. The good question is initially radiochemotherapy with salvage cystectomy if needed as good as initial cystectomy? You understand why I asked this question? The idea is, if we can rescue the patient that will progress under radiochemotherapy, we may probably save some good functioning bladder and save the others going to radical cystectomy. So what are the data in the literature comparing salvage cystectomy for relapse after radiochemotherapy and primary cystectomy for a bladder disease? Well, we have some data. How here? This has been published by the European Urology. And if you look to the comparative data on salvage cystectomy and primary cystectomy, in terms of percentage and p-value, none of those goes to statistically significant difference. That means that in those hands, there is no difference in terms of toxicity added by salvage cystectomy as compared to radical cystectomy. As Morgan said earlier this afternoon, radical cystectomy is a difficult and toxic treatment, but apparently in good hands, it could not be more toxic after radical radiotherapy and chemotherapy. Efestaciou from MGH also said something like this: salvage cystectomy for recurrent invasive disease identified during follow-up with close cystoscopy surveillance did not confer worse outcomes when compared to immediate cystectomy for a known responder. And we have also some data that have been published in this field. So, after all I've said, I may be convinced you or not, but then you have studies like this one coming out in JAMA Surgery, which is not the last of the papers, of the journals, as you may know, comparing survival outcomes and costs associated with radical cystectomy and trimodality therapy for older adults with muscle-invasive bladder cancer. Conclusion. I don't go into much details, it's not the idea. Our study has several important findings. First, patients who underwent trimodality therapy instead of radical cystectomy had a significantly lower overall survival rate. Second, this was published 2 years ago. It's very recent material. Although cost did not differ statistically at 30 days, at 1 month, later on, trimodality therapy was associated with higher cost at 3 months and at 6 months. Why is that, in your opinion? Are you aware of these studies? Because this has been quoted a lot by my colleague when discussing patients in our multidisciplinary clinic. Why those results? After all I told you. Because those results are coming from the SEER database. Are you aware on what the SEER database here is? The SEER database in the States, it's a huge basket of data coming from patients treated everywhere in the country where you cannot control as you wish for all details of each patient. You adjust the age, that's why they are meaning older age, this you have. You have the outcome, you have what they've done, no control on what kind of patients they have been treated there. So whenever you see SEER database, and not only for bladder cancer, also for prostate cancer, be aware that you are looking at data which are not at all comparable. And after all I told you today, well, no surprise that if you don't control for the several exclusion prognostic factors that I've told you, this is what you risk to have. Older patients with bigger tumors, with CIS everywhere, with hydronephrosis, of course they are not doing good. Radiochemotherapy is for selected patients, is not for all comers. And this should be very clear when we speak to our patient, that's for sure. So these are my conclusions. That I leave you the question. Radiosensitizing agents substantially improve local control as compared to radiotherapy alone, do you remember? Selection of patient is key. I'm not pretending here that radiochemotherapy is good for all patients. Better radiotherapy techniques may help in having less side effects. We may discuss this later if you want. Salvage cystectomy, for what is published in good hands, does not seem to impact survival as compared to primary cystectomy, and this is a good message for our patient. It's time to reevaluate bladder-sparing preservation therapy. I think, like Mary Gospodarovich said, radiotherapy and organ preservation in bladder cancer, are we ignoring the evidence? Probably yes. But I have to admit that the UDOU guidelines, even if any radiotherapist is in the panel, they have integrated multimodality therapy as an alternative to select well-informed and compliant patients. And he says, of course, especially for whom radical cystectomy is not an option. But I think I am happy for our patient that this has been integrated by a panel of known radiotherapists in the UDOU guidelines. If you have more, if your idea are more confused after what I told you today, give a look to this paper. This is the UDOU ESMO Consensus Statement on Management of Prostate Cancer. It's a very recent publication, 2019. There are a few radiotherapies that you may recognize in the list there, but it is totally incredible document. You may read it. Everything is said, the contrary of everything. When you put together such a long list of people, you can get a very interesting conclusion, believe me. But this may, you know, worthwhile reading one evening if you have nothing better to do. I thank you for your attention. And we check if Enrique is still. No, he is sleeping. Ah, okay, okay. I was too long. I'm sorry. Questions and comments?
We already have a blended pelvis, so the surgery will be really difficult. And is it possible to do a radiotherapy after 55 grays on the bladder? So we are limited for the radiation of the prostate. So this is the main problem that we. No. If we do a bladder radiotherapy, a three model therapy for a bladder cancer, and the patient develop a prostate cancer, yes, the surgery will be really difficult with high risk, and for the radiation, it will be also difficult to give maximum radiation for the prostate. So what should we do in these cases? If we use the three model initially.
You have, I mean, your question is, we just use the technique of radiotherapy there, we cannot replicate it for a second cancer in the same region, which is.
I don't know. I'm taking your advice.
There are two things to say. In general terms, you are right. Because of course, when you didn't want to go into much technical details, but the radiotherapists here in the room are well aware that when you irradiate the prostate in such a situation, you also irradiate the bladder, sorry, the bladder, when you irradiate the bladder neck, and so part of your prostate will also be in the high dose region, okay? But I have some experience, some extensive experience in prostate brachytherapy. And I have done a few cases in which brachytherapy was asked exactly for a patient like the one you were telling me. Or, for example, patient that first had some external beam radiotherapy for anal cancer, for rectal cancer, preoperatively. And I'm telling you, brachytherapy for those patients is a very good option. So, treatment, retreatment in a high dose, in a region which already was treated with high dose radiotherapy is not impossible. You are probably aware of stereotactic body radiotherapy. We will touch this tomorrow when talking about the role of radiotherapy for kidney cancer. Stereotactic body radiotherapy may allow you to irradiate also in this situation with good results. So it's not a totally lost case, if I may. Yeah. Yeah. Well, there are some data out there, but the level of put on this because I don't want to. The level of evidence is very, very low. So I would strongly discourage any patient in this situation to go for a three-modality approach. The data we have are for muscle-invasive cancer, and I would be very, very prudent to suggest that something else could be, that the same strategy could be done for other patients. Yeah. Yeah.
Thank you, Dr. Alberto. I have some question for your. I'm a radiation oncologist. I work in Cherbourg, Normandy. In practice, you get the patient for organ sparing approach. So, what type of chemotherapy schema you used, and how do you evaluate? When do you evaluate the half in 40 gray or something like that? Yeah.
So you got the answer. Huh? The answer is what kind of. I told you about two protocols, two strategies, which is the one that I do. We do at Gustave Roussy the second one, the European way. We are not re-evaluating the patient mid-term, okay? Why? Because even if we are a big center with a lot of experience, it's still very difficult to organize things in our hands in order not to make our patients waiting too long, okay? You don't want your patients to have this cystoscopy with biopsy too long after you stop your radiotherapy. You don't want to wait too long to have the results. You understand? And this in our hands is still a little bit complicated to organize. So we go for the full Monty. We go till the end as the Germans proposed because we find it easier from the practical point of view. For the second question, we are using more and more the Nick James protocol with 5-FU and mitomycin. I found it probably better tolerate to patients in associations with radiotherapy. I would discourage, this was also a message earlier this afternoon, to use carboplatin. Cisplatin, we have a lot of experience. Carboplatin is probably less active in this respect. So I would discourage, as Enrique also suggested, the use of carboplatin. Go for cisplatin if you want. And the other question, which is very important, is how to organize the follow-up of those patients. Here you need a very good cooperation with your surgeon, because again, I'm not doing cystoscopy. I have no experience in cystoscopy. It is the surgeon doing cystoscopy. Okay, so again, you need a very good cooperation with your surgeon. If I may, there was this sort of misunderstanding, in my opinion, in the world of oncology, of genitourinary oncology, that if a patient asks for trimodality therapy, well, this is a lost patient for the surgeon. I also hope you have understood that this is not the case at all. First, because 20% of those patients at 5 years will need cystectomy. You have seen that in those data. But also because for the follow-up of those patients, we need surgeons, well-trained surgeons, convinced surgeons that what we are doing is correct for the patients. So it's not stealing patients to no one, as it may be for prostate, I have to admit. Not at all, not in this respect.
Thank you for excellent lecture. First thing, at least you convinced me about the trimodality, because as we know, the radical cystectomy is the gold standard for the treatment of the cancer, muscle invasive. Now, in the real life, okay, if you're thinking about the median age of the cancer, muscle invasive cancer, bladder cancer, it's a 75, 80. Okay. Usually, this certain age, there is a lot of comorbidity with the patient. And as you mentioned before, that the radiotherapy and chemotherapy, it's toxic. Okay. And if you compare it with the cystectomy, okay, the patient sure will choose the cystectomy because it's one operation. Okay. On the other side, the trimodality, you need the follow-up, cystoscopy, chemotherapy, and radiotherapy, and at least maybe the distance you will go to he needs a radical cystectomy. What do you think about this?
Honestly, I think you are right. It's something you have to discuss with your patient. I think that selection of patient for trimodality therapy is key, much more than for cystectomy. You may treat with cystectomy all comers. This is not the case with trimodality therapy, so I do agree that you have to select your patients. But I also agree there was a debate at ASCO a couple of years ago on this topic, and a surgeon had to admit, a good one, doing radical cystectomy for those kind of patients, he had to admit that surviving with your own bladder is certainly better than whatever solution a surgeon can give you in terms of diversion. So if you have a patient that has a very good functioning bladder, if he goes into those clear-cut factors, selection criteria that I gave you, I really think that you may propose him radiotherapy and chemotherapy, aiming at saving his bladder, probably a little bit longer in time, not definitively. He has to be, of course, informed about what you said. He will risk to have a relapse in his bladder 20% of the case at 5 years. But it's totally different than imposing to a patient something to do. This, I think, is the main take-home message for today.
I'm thinking about the complication of the surgery,
Yeah.
complication of the radiation.
You remember what Morgan said earlier on.
Yeah.
Radical cystectomy is not a very easy operation. He also mentioned the fact that there are, at least for what I know in England, very strict rules in order to define the centers that are allowed to perform radical cystectomies. Not everybody can do this. They have fixed an amount of surgeries you have to do per year if you want to get the patent as a center allowed to do radical cystectomy. I am also convinced that this should also work for radiotherapy. I told you immediately that this is not something that you have to invent in your center of radiotherapy just because you have heard someone speaking at a teaching course of UDOU. No, 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 no. This is not the way to go. But I'm also convinced that this is not the way to go if you perform radical cystectomy on all your patients. You understand what you mean? If you are not doing more than 10, 15 radical cystectomy a year, I'm sorry, but it's clearly shown in the literature that you risk much more side effects than the one who is doing 50, 60, 70 radical cystectomy a year. So it's really a complex, multifactorial equation to get to know what is the best approach for your patients, I think.
Also in the patients that are doing the treatment
Yeah.
how is the quality of life after?
That's a very good question. I have to admit that the modern radiotherapy technique, because of course chemotherapy is more or less the same that was proposed 40 years ago when this protocol were invented, the quality of radiotherapy has changed a lot. And of course, we don't have time to go into much details, but believe me that there are also publications clearly showing that the rate of local toxicity due to radiotherapy can become very small if you do modern radiotherapy techniques. It's not easy task. That's why I was telling him that these need centers with good experience in managing radiotherapy in this situation. But you can get now strategies, radiotherapy strategies, in which the toxicity is not that high anymore. I have a big bias. I'm doing a lot of brachytherapy. And I've seen also brachytherapy for bladder cancer. I don't want to, to make my message confused, also mentioning this. But what is the potential of brachytherapy applied to bladder cancer? The potential of brachytherapy is you will concentrate the dose on a unifocal disease without giving high dose everywhere else in the bladder, if not needed. So there may be a role for improving radiotherapy techniques and getting rid of this toxicity, which is certainly linked to such treatments. Okay, gosh, it's 6:30. I think we can finish here with the first day. Thank you for your courage to resist up to now. Some information for the evening and for tomorrow?
Yes, just we are meeting